Good evening.
Hi, Dr. Preeti, hi, Deepika.
Hi,
Pranam,
Dr. Namit.
yes, sir, ma'am, Pratam.
Yeah.
Pranam Chandravati, ma'am.
नमस्ते।
मेरे को
प्रणाम
डॉक्टर मंजू
निवेदिता।
शुक्ला मैडम दिख नहीं रही है। डॉक्टर मंजू शुक्ला मैडम दिख नहीं रही है उनका। मैम, आपका
अभी तो
वीडियो ऑफ है।
अभी तो
प्रणाम मैम।
मैम अभी तो
दिख
थे,
रही थी पूरी पूरी।
अभी तो दिख रही थी मैडम।
अभी तो दिख
अभी तो
रही
पूरी दिख रही थी।
अब आ गई, अभी आ गई मैम ने भी।
प्रणाम मैम।
हाँ
मैम म्यूटेड है।
मैम अभी अभी सिजेरियन करके आई हैं।
अरे वाह।
सो
अभी नहीं, सिजेरियन तो सुबह।
अच्छा मैम, आप कह रहे थे ना बेबी इज इन द ने एस्पिरेट किया।
हाँ, नहीं उसको बाद में उनकी रिश्तेदार ने फीड कराया ना, तो
अच्छा, तब एस्पिरेट कर लिया। अच्छा अच्छा, नॉट एट सिजेरियन। ओके ओके।
पहले मिल्क एस्पिरेशन हुआ।
मिल्क एस्पिरेट, हाँ हमें कुछ और लगा। ठीक है, मिल्क एस्पिरेट कर लिया। ओके। डॉक्टर मोनिका, आई थिंक अब लाइव स्ट्रीम हो रहा है बिकॉज रिकॉर्डिंग आ रही थी अभी यूट्यूब पे।
Yes, ma'am. We are
यूट्यूब
live
चला
now,
गया
so
लाइव, तो आप इनॉग्रेशन तो कर ही
start
सकते
कर देते
हैं। हाँ
हम्म,
Yes, ma'am.
हाँ, we can start, no issue.
Okay.
फिर
A very
बाकी
warm
तब तक
welcome.
जुड़ जाएंगे।
Yes,
यस
हाँ,
यस।
sir. A very warm welcome to all the esteemed faculty members and the delegates who have joined us today for the Happy Learning Masterclass webinar series. This is the 245th episode with Faizabad, Lucknow, Moradabad, Shahjahanpur, Hapur, and Sultanpur societies. Today's theme is mixed bag, and the program director for this program is none other than Dr. M.C. Patel, sir. Before we start the program, let us evoke the blessings of Lord Almighty. Can we have the inauguration slide, please? The tech team. Thank you. It is my proud privilege to introduce our program director, Dr. M.C. Patel, sir, your candidate for Foxy presidential election 2026. Sir has been the vice president of Foxy in the past chairperson of the Medical Legal and Ethics Committee. Sir has also been at the helm of Ahmedabad OBGYN Society at IMA Ahmedabad and at NMO. Sir has also been in active service in the last 23 years in the Northeast as well as in Jammu and Kashmir. Sir also has been an important medical legal consultant across Pan India. This started as academic sharing platform in 2020 during the time of COVID when physical meetings were not allowed. This family has grown to now more than 10,000 gynecologists who have joined us today in some or the other way. Sir, it is a proud privilege to coordinate this program, and we welcome you for your welcome address to the August gathering.
Thank you, Dr. Monica. It gives me immense pleasure to welcome you all on this 245th episode of Happy Learning Masterclass web series. As mentioned, joining society Faizabad, Lucknow, Moradabad, Shahjahanpur, Hapur, and Sultanpur. I welcome Dr. Chandravati Madam. She has kindly consented to be chief guest to bless the webinar. I am lucky. She is always with me. Whenever I have called her, she is always there to bless me in any of my academic activity. Welcome, madam, and thank you for sparing time for me. I also welcome two guests of honor, Dr. Manju Shukla, madam. Again, she is also with me always in any of my academic activity. She has also kindly consented to be guest of honor. And Dr. Priti Kumar, my younger sister, she is always with me in any of my academic activity. Whenever I have called Preeti, yes, it will be done. And today is also the same thing. So welcome Preeti, and thank you for sparing time in spite of your very, very busy schedule. You are here to join this webinar to bless the webinar. I also welcome set of chairpersons, Dr. S.P. Jaiswar madam from Lucknow, Dr. Raju Tyagi madam from Lucknow, and Dr. Ritika Agarwal madam from Muradabad. They are going to share very interesting session about adolescent endometriosis, current concept, and it will be dealt with by Dr. Sonu Singh madam from Lucknow. I also welcome one more set of chairperson, Dr. Anjana Agarwal madam from Hind Institute of Medical Science, Dr. Anubha Dudia from Hapur, Dr. Rastogi from Lucknow, and they are going to share very interesting session about adnexal mass in adolescent evolution and management update. And it is going to be dealt with by Dr. Neha Nigi madam. I also welcome one more set of chairperson, Dr. Akhilesh Dwivedi from Lucknow, Dr. Deepsika Goyal from Hapur, Dr. Seema Mehrotra from Lucknow, and they are going to chair session about records, always at your rescue. It will be dealt with by me. I also welcome two learned moderators. They are going to moderate very interesting panel, Dr. Monica Agarwal and Dr. Varda Arora from Lucknow. And in that very panel, to have her expert comments, Dr. Uma Singh madam is there. I welcome Dr. Uma Singh madam also. And I welcome all the learned panelists, Dr. Nisi Singh madam from Faizabad, Kanchan Prasad from Muradabad, Renu Bansal from Hapur, Dr. Richa Pandey from Barabanki, Dr. Sailja Bapri madam from Barabanki, Neha Chandra from Muradabad, Sonam Rastogi from Muradabad, and Dr. Richa Agarwal from Muradabad. I also welcome my own team, Dr. Monica Umardan. She is convener for this series since long, and all coordinator, Dr. Monica Gupta from Alwar, Dr. Nivedita from Bokaro, Dr. Deepika Logani from Delhi, Dr. Satabdi from Siliguri, and Dr. Megha from Kalaburgi. And I also put it on record, special thanks to Dr. Seema Mehrotra. She has taken lots of pain as far as this webinar is concerned for designing and for execution of this webinar. Thank you, Seema, all the pains you have taken for us for this webinar. I also welcome all the president and secretary of respective society who have joined this webinar and all the delegates and friends. So welcome to this 245th episode of Happy Learning Masterclass. As mentioned, in era of COVID-19, when I started this series with 3 people, now it is a big family of Happy Learning Masterclass. And at that time, my aim was to meet our Foxian friends on virtual call, say hello, and discuss focused topic and to be helpful to our professional colleague in their day-to-day practice, how to deal with all this situation and how to get rid of this type of situation whenever you are held up in this type of situation. But ultimate goal was to check maternal mortality and infant mortality, because by 2030, Government of India and WHO has given us a target that infant mortality rate should be less than 12 and maternal mortality rate should be less than 70. So there are so many states, even today, they are already having less than this rate. Say, for example, Kerala, less than 30. But at the same time, there are few states, particularly in northern India and particularly northern eastern India, where maternal mortality was 200 just before a few months. Now it has come down to 200, but still it is long way to go. And it is of course possible to reach the goal, but with joint hand only. So on part of government, federation like Foxy and IMA, NGOs, and our Foxian friends, particularly who are working in remote rural area, and if they go joint hand, then maternal mortality can be checked and goal can be achieved. So with this aim, we are discussing very focused topic every time. And today, one more episode with this. And before I conclude, I thank you all, the President and Secretary of respective society, for your generous nomination for my candidature of President Foxy. So as they have reciprocated me, and it has come to my notice that I have got highest number of nominations as far as my election campaign for President Foxy is concerned. So thank you for the same, and please continue same blessings at the time of voting. Voting will be from 1st August to 10 August. So with this, thank you very much.
Thank you, sir. Thank you for the opportunity to coordinate and this program. It is my proud privilege to introduce our chief guest, Dr. Chandravati Madam. She is a highly esteemed obstetrician and gynecologist in Lucknow, practicing as a director and chairperson of the gynecological services at Krishna Medical Center. With more than 50 years of experience, she specializes in high-risk pregnancy, infertility, and minimal invasive gynecological services. She was the former head of the department at the Queen Mary's College and Professor Emeritus at KJMC, the past president of Foxy. We welcome you, ma'am, and we request you for your blessings. You are a motherly figure to most of us present here, ma'am. Thank you
Thank
for
you.
the guidance always, ma'am.
Thank
Yes,
you,
ma'am.
Monica. Thank you very much.
Ma'am, we request you to please share your words of wisdom with us.
Thank you, Monica. It's a pleasure to be connected to this thing because MC had been very, very close to me, and I've known him for ages. I think he is the right candidate for presidentship, and that is why so many societies have even nominated him. I know he's wonderful. He's going to do the maximum job. He was going to take the Foxy to a greater height, and I wish him all the luck and blessings are with Dr. Patel. And I am audible.
Yes,
Yes,
ma'am.
ma'am.
Yes, ma'am. You
Yes,
are
ma'am.
audible.
So all the wishes are with MC, and I wish all the friends and everyone, known colleagues, I will always tell them to vote for him, and I wish that he becomes the president of Foxy this coming time. Thank you.
Thank you, madam, for sparing time and to bless me. Your good wishes will work. Thank you, madam.
Thank you.
Thank you, ma'am. Now I would request Dr. Monica Gupta, madam, to please introduce our guest of honor for today.
Thank you. Thank you, Monica, for giving me this honor. And thank you, MC sir, for making me part of this marathon webinar. Our guest of honor for today are Dr. Manju Shukla ma'am and Dr. Preeti Kumar. Please put the CVs. Dr. Manju Shukla madam is a retired professor from Lucknow, from KGMU and CIMHS hospitals. She was a president of UPCOG, President Lucknow OBGY Society, Chief Editor General of UPCOG, President Association of Private Gynecologists of Lucknow, Master Trainer of Contraceptive Technology by Japaico, Master Trainer IMOC, Master Trainer in Maternal Health, trained in Quality Assessment and QAS National Assessor Quality, and Lakshay Kayakalp in NRHM, and she has received Lifetime Achievement Awards from Lucknow OBGY Society, UPCOG, IMA Lucknow, Khushi Foundation, and TO Viva. Over to you, madam, for your blessings. Manju ma'am.
Thank you, Monica. And thank you, Dr. Patel, for inviting me. I am really honored to be guest of honor and for this webinar. This is marathon webinar, as Monica said. And the topics chosen are very, very good, so that all the people who are attending this webinar will be benefited by this discussion, and to wish Dr. Patel this every time I wish him, I bless him, I give him आशीर्वाद, सर पे हाथ रख के
Dr.
आशीर्वाद.
Vardha Arora, please unmute yourself.
And my wishes are with him for every venture, everything. And I wish all the success to this webinar. And thank you very much.
Thank you, madam. You are always with me and you have always blessed me. I am
Yes.
lucky that way.
Yes.
Yes, madam.
Thank you, ma'am, for your blessings. Our next guest of honor is Dr. Preeti Kumar, madam, our own Vice President from North. And she is a very dedicated person. Her passion for working for the PPH projects is commendable, and we all have seen her a lot of work. She is working with Foxy FICO PPH project in UP in 10 public facilities and 2 medical colleges, KGMU and BHU in 2023. She's a core member of Prevention of Violence Against Women Cell of Foxy and Publication Cell Foxy. And she was the organizing secretary of Narchicon, AICOG, Lucknow Justices, AIGE,
much,
and
Monica.
whatever she has organized, they all are superb. And she is being the chairman of Safe Motherhood Committee, and she is the right person who can reduce the maternal mortality in UP. Over to you, madam, for your
Thank you
blessings.
so much, Monica. Thank you. Thank you for your kind words. Regards to Dr. MC Patel, sir. I really treat him like an elder brother. And respected Dr. Chandravati, madam, and Dr. Manju Shukla are my teachers, and sharing dice with them, it's a great honor itself. What I want to tell about Dr. MC Patel, sir, is I've been observing him for years now. What I've found is he's a very silent worker. He never ever will post his achievements. He will never let people know what he has done, but he silently works. And I think for last 4 years, he has been traveling a lot all across several societies. And I think he has covered most of the societies so far. I think none of the presidents have covered so far so many societies in person. And the second thing that I really want to appreciate about Dr. MC Patel, sir, is whenever you are in a medical soup or you have any medical legal problem, he is always there to help and guide without any charges. So that's the biggest achievement and a compliment for Dr. MC Patel, sir, because he's the backbone for all of us as far as the medical legal issues are concerned. So we need people like Dr. MC Patel, sir, in Foxy who are really dedicated, committed. And I think for last 4 years, he has been he has worked so hard for this. I think every society he has tried to cover all the medical legal parts and wanted to protect the every OBGYN of Foxy. So I wish, sir, we, myself and Seema decided the topics that let us keep these topics because these topics should not clash with the upcoming CMEs of logs. So that is why we selected such topics. So they are of interest and as many people from Lucknow society can join this webinar today. So, and we have selected very, very good, faculty from Lucknow. All of them, though they look young, but Neha, Sonu, Varda, they are very dynamic people and they are working, they have immensely worked in the field of Obs and Gynae. And all the faculty who have joined from other societies also. Thank you so much for making me part of it, making me guest of honor for this webinar. I'm always there for you. Wish you all the good luck and all the coordinators who are working hard with sir. Applaud to you all also. Monica, both Monicas. Thank you for being there with sir and helping him throughout the webinar series of this Happy Learning Classes. Thank you so much. Thank you and wish you the best for this webinar.
Thank you. Thank you, Preeti, for sparing time. I know you are very, very busy in your all this activity related to Foxy, being a Vice President of Foxy this year. But even then, you have spared time for me. It shows your love and affection to me, and I am always obliged for the same. Thank you. Thank you, Preeti.
Thank you, ma'am, for your kind words. And with sir's permission, should we start with the
Oh, yes.
academic
Oh,
program?
yes. Oh, yes.
So, good evening to everyone from Delhi. I'm Dr. Deepika Lugani, and at the outset, thank you, Dr. MC Patel, sir, and thank you, Dr. Monica, both Monicas, for giving me this opportunity. And I will take you through the first session. And we begin our first scientific session with the permission of Dr. MC Patel, sir. And the topic for this session is adolescent endometriosis, current concepts and clinical challenges. It is now my proud privilege to introduce our esteemed chairpersons for this session. Our first chairperson is Madam Dr. S.P. Jaiswal, ma'am. Could we have a CV for Dr. Jaiswal, ma'am? Could we have a CV, please? Next, please. Next, please. Yeah. So, ma'am is the professor and head of department Obs and Gynae at ERA Medical College, Lucknow. And ma'am is the former professor and head of department Obs and Gynae at KGMU, Lucknow. Ma'am served as the president of Lucknow Obs and Gynae Society and as the president of ISOPAR from 2020 to 22. Ma'am has numerous publications to her credit and has received several awards, including the International Women's Day Award recently in 2025, Excellent Service Award from KGMU, and the Outstanding
Thank you, Dr. Deepika. Thank you so much.
Thank you, ma'am. So we welcome you as our chairperson, ma'am. We are a warm welcome to you. Our second chairperson for today's first session is Dr. Rajul Tyagi, ma'am. Ma'am is the chairperson of ISAR UP chapter and the president of the Association of Private Gynecologists of Lucknow. She's also the vice president of ISPAT Managing Committee and ISPAT UP chapter. Ma'am is the director of Javitri Hospital and Test Tube Baby Center, Lucknow, and Javitri Institute of Paramedical Sciences, and heads the ART unit, a high-risk pregnancy unit and genetic clinic at this hospital. Ma'am has numerous awards and many publications to her credit, including the Women's Achievers Award conferred by the Governor of Uttar Pradesh. We welcome you, Dr. Rajul, ma'am. Our next chairperson for the session is Dr. Ritika Agarwal, ma'am. Ma'am is the president of Moradabad Obs and Gynae Society. She is a consultant obstetrician, a gynecologist and infertility specialist, and a professor at Venkateshwara Institute of Medical Sciences, and a senior consultant obstetrician and gynecologist at St. Joseph Hospital, Rampur. Ma'am, we welcome you as our chairperson. And could I invite one of our chairpersons, Dr. Jaiswal, ma'am? Could you introduce our speaker for the for the first session, Dr. Sonu Singh, ma'am?
Definitely.
Thank you,
Good
ma'am.
evening to all of you. And thank you, Dr. Patel, who has involved me in this series. I know Dr. Patel, he's such a sincere person, and I know from so many years. And I asked him to come Lucknow for oration also in KGMU on the foundation day of Queen Mary Hospital. He's such a knowledgeable person, and we wish him for his great success. Thank you so much. Now we are coming on the academic. Please display the CV, not mine, Dr. Sonu.
Please display the CV. Yeah, that's right.
Yeah.
Thank you.
Dr. Sonu Singh, she is MS, FMS Fellowship in Advanced Gynae Laparoscopy, trained in Gynae Oncology from Tata Memorial Hospital. She is having certified fellowship of AAGL and IJ, and recipient of IJ Skill and Excellence Star Award. Currently, she is working as a chairperson of Department of Gynae, Chief Gynae, Endoscopy, Endometriosis. I know she is working in the Chandan Hospital, and she is a very good laparoscopic surgeon. Always she put something news and some about his successful surgery on our group. So I know she is a very laborious and very good surgeon. So now she is going to speak on a problem which is a adolescent endometriosis. Nowadays, day by day, as PCOS and endometriosis, both are increasing in young age. And we are receiving so many young girls, unmarried 15, 16, 17, 18 years girls, they come with such pain. And we know as the endometriosis is a very although it's a benign condition, but it's very problematic to the woman. So now Dr. Sonu is going to cover this. Thank you, Sonu. Come.
Thank
Dice
you.
is yours.
Thank you, ma'am. Am I audible?
Yes, yes, Dr. Sonu. Please, you can
So, good
share your
evening.
screen. Yeah.
Okay. Good evening, everyone, and my special regards to all my seniors who are present over there. And so I'll start sharing.
Yes,
And
ma'am.
MC Patel, sir, Chandravati, madam, Manju Shukla, ma'am, and everybody from my Locke Society who has given me so much of honor and love always. So,
All the stalwarts of Uttar Pradesh are today all with us,
yes.
big societies.
So it's a big honor for me to present in front of them.
That's right.
So, my screen is visible or not?
Ma'am, your screen is visible. Please open the presentation.
Okay, yeah.
Double click.
But
it.
my
And-
laptop screen is visible, no?
Yeah, now
Yeah,
we can
yeah.
see the presentation. Now go on full screen, ma'am. Or
Okay.
slideshow.
Okay.
Ma'am, ऊपर जाइए जहाँ transitions,
I can
animations,
see, I
slideshow.
can see, yeah.
Yes, ma'am.
Okay. But
मैम slideshow पे जाओ अभी आपने tools खोल दिया. Play from start.
सोनू नीचे आओ, देखो एक स्क्रीन वाला जो बना है ना, उसको
First
क्लिक कर दोगे तो फुल स्क्रीन हो जाएगा. हाँ, एक स्क्रीन वाला नहीं, इसके बगल में जाओ और
No,
बगल
no,
में
no. There's a cup. Put on
कप
cup.
जैसा, हाँ कप
cup,
जैसा
cup.
जो बना है ना, और बगल में आओ, हाँ ये
Here.
वाला.
Yeah.
Yes,
okay. Thank you. Thank
Perfect.
you.
बिल्कुल ठीक.
Chal,
So,
let's continue.
this topic is actually very interesting because I deal a lot in endometriosis surgeries, and adolescent endometriosis, I really believe it is something which we were not knowing much. And this is the phase which really needs lot of, emphasis and our concern. Because if we look at these data, which is not quoted by me, but rather these are the ACOG and ESHRE themselves, they have quoted this data, that if we do laparoscopy in all the females who complain of chronic pelvic pain below 20 years of age, about 65% of them will get endometriosis or signs of endometriosis on laparoscopy. But the main problem is we are detecting their problem very late. On an average, there is a delay of about 7 to 10 years. And if we believe that endometriosis is something which is affecting only the women in the reproductive age group, then the studies have shown that in few studies, they have even found the symptoms as early as in a female of 11 years. So the question here comes is, are we recognizing endometriosis too late? Or whatever we see in, in the patients in reproductive age group, patients with infertility coming to us, and they are always like in stage 3 or stage 4, as I see in my OPD and during the surgeries. So is the advanced disease which we detect is the result of missing those diseases in their adolescent age group? So this is the publication which is telling about this incidence in adolescent. So I will not go much into detail of the different theories about endometriosis, how does it occur? But if we look at the different pathogenesis theories, then the second theory, that is the coelomic metaplasia, it becomes relevant in the context of these young girls coming to us having these symptoms even in premenarchal cases. So there is some kind of metaplasia happening. Then the role of genetics is obviously there. A lot of immune dysregulation happening at so young age, and especially the time when they start their periods or they enter into their menarche. So the important key features in these women, in these little girls, especially adolescent age group, the disease profile is little different. That's why we are missing them. Why? Because many times this kind of pain is being normalized, not only by the family members, but also by many of us, many of the care providers, because there are many overlapping symptoms as well. And also, if we look and at the ways of detecting or diagnosing, the imaging is lacking in these girls. There are most of the time their ultrasounds and MRIs, they come out normal. And even the studies have quoted that the type, why we are missing them on MRI, because the lesions are not the typical lesions which we find in the later age groups. These lesions are very atypical. So all this I will discuss in the next slides. So these adolescent endometriosis, why we are missing, why this disease is being missed. So there are various, ways, or there are various platforms where we fail them. One is definitely picking up the symptoms. Again, because of many times we get confused with primary dysmenorrhea, which occurs because of the prostaglandins, and secondary dysmenorrhea, which is pathological. And the symptoms of bowel and bladder, the vague symptoms of fatigue, anemia, lack of concentration, all these sometimes, we miss these clinical features. Then definitely again, the problem with imaging, that we are not picking the superficial lesions. MRI fail to pick these superficial lesions. And if the scans come normal, then we feel that maybe it's not endometriosis. So diagnostic delay is a main problem in these women. So again, we will talk one by one. So let us first talk about the clinical presentation in adolescents. We know that dysmenorrhea is the most common and often the severe, most common symptom and in these girls. But the main thing here is how to detect. If you are giving them some kind of treatment in the form of NSAIDs or COCs, and these girls do not respond to this kind of pain, then always one should have high suspicion of the girl being suffering from endometriosis. Then the other symptoms, like sometimes we believe that we ask them, is your pain related to menstruation? And they tell that no, it's always like it is more of a chronic pelvic pain kind of thing. Then it is being seen that in about 50% of the cases, the girls report acyclical pain not related to their menses, and that does not exclude endometriosis. And we have to again look on the other symptoms of GI symptoms like bloating, nausea, vomiting, which may be present in about 90% of the patients. So definitely a good clinical history, just poke in their history, what kind of pain they are having, ask them to maintain a diary of their symptoms, ask about their family history, their bowel and bladder symptoms. And definitely examination is something which is not that much feasible in this age group, especially per vaginum or rectovaginal examination. Sometimes it is very painful. So this is one limitation. So what are the red flags which suggest endometriosis in adolescent? So again, the same severe dysmenorrhea, which is not responding to your hormonal treatment or NSAIDs, which we often give in this age group. The symptoms are both cyclical as well as acyclical. She is having, problem of school absenteeism, fatigue, and there is family history. So these are said to be the red flags which should alarm us. Then imaging challenges, ultrasound is said to be the best for endometriosis, the first line investigation, but again, it misses and it only detects when the ovary gets affected and we get one endometrioma. So I think this is even all the societies, they have recommended that for adolescent age, MRI pelvis is the preferred modality of imaging to detect endometriosis. But again, MRI is something which is missing these superficial lesions. So even if the scans are normal, do not think that the girl is not suffering or may not suffer from endometriosis, because normal imaging does not exclude endometriosis. Even on laparoscopy, if we detect these lesions and we take biopsies, there is a problem, again, a challenge of histological confirmation, because these lesions are different. Sometimes we get very inadequate biopsy samples because of the superficial small lesions. They are not present in the depth, and also their morphology is little different. So surgical diagnosis, in books it is written that laparoscopy is the gold standard. So definitely it is the gold standard when we are confused, when we are not able to, we are uncertain about our diagnosis. So the ACOG has clearly said that in this age group, we don't rely completely, or we don't wait for the laparoscopy to start our treatment. If even on clinical suspicion, we can start our empirical treatment and see how the symptoms are responding to your treatment. So again, the atypical lesions, which I will be showing in the slides and in the videos. And of course, we have to stage these girls. And if it is advanced stage at the time of detection, then definitely surgery is the option. But our main goal should be to detect them at early stage. Now, why? Usually there is endometriosis evolution. We know that every disease, it has different stages. And nobody develops a stage 3 or stage 4 immediately. So definitely we are missing the early stage lesions. So adolescent disease is more of a neuroinflammatory disease. And the deep lesions are detected, or they usually takes time to develop. So our main aim should be to how to catch these initial stages, these mild to moderate stages of endometriosis, and help our girls which suffer later on with extensive complex surgeries, which may involve different complications and post-op, long prolonged suppression. So these are the laparoscopic findings, which we often see in the adolescent. Now, these are different. You can see they are so subtle. One may miss if one is not very aware about this disease. On laparoscopy, you can miss these lesions, which can be very, like here you can see it is so subtle, just a little reddish vascular lesion. But these are very active, lesions. They cause a lot of pain because they are affecting the nerves. Now here only just a puckering of the peritoneum. Here you can see very clear or transparent lesions along with a red lesion. And sometimes we get only these kind of peritoneal folds, which are the Allen-Masters pockets. And these are the typical lesions, which usually are less commonly present in these girls. So contrary to what we have seen there, these stages are not the initial stages. These are the stages which need to be tackled surgically. Why? Because this is now anatomical distortion. Tubes are totally, stuck with the ovaries and on the pouch of Douglas. So will your medical treatment help them in, sorting out this kind of adhesion? No. So definitely if somebody is having stage 4 frozen pelvis or severe symptoms, then these are the girls which need surgery also. Now coming to our first line of management, medical management. Little girls below, before 20 years, we all start with giving them first line, which is the NSAIDs. And we NSAIDs, usually we combine them, or sometimes we also add COCs, the contraceptive pills, which should be given in a continuous manner, not in an cyclical manner. We try them, and if the girl is responding to your treatment, we can go ahead and escalate your treatment ahead. Now, the second line, if she doesn't respond to your COCs, in these girl, we can also start with the Dynogest or the progestins, but clearly the guidelines have stated that if Dynogest is you are giving for a longer duration, then always take care of her bone health also, and start with vitamin D and calcium. So bone mineral density is something very concerning in this age group, because these are growing, girls. Third line drugs, which are very, rampantly being used, GnRH agonist, leuprolide, and GnRH antagonist, the new drugs, elagolix and relugolix, they are not recommended for this age, and they have very limited, data we have in this age group, and they cause lot of, bone loss. So if you are giving leuprolide to these females by any ways, always add your add-back therapy along with it. Now, again, little word about the surgical indications. If any of your medical treatment is not responding, you feel that the size of the endometriomas and the symptoms are progressively increasing, if you feel that on MRIs, some organ damage in the form of hydroureter or some kind of rectal lesions, some kind of nerve involvement is being shown, then these are the girls who should go ahead and undergo some surgery, perfect surgeries. Most of the time, we have seen, like many of my adolescent age group girls, I have seen also associated Mullerian anomalies. Many had, superficial endometriosis and also ACM associated with that, sometimes rudimentary horn with a hematosalpinx and endometrioma on the same side. So these are the girls who need upfront surgery. So this one video is just to show that, she was only 16 years and she had debilitating pain. You can see the inside picture. Many cycles, the cyst used to like rupture. So you can see a lot of deposits, the endometriotic spots all over the peritoneum and deposit everywhere in the abdomen. These are basically because when the cyst, it ruptures, and again, there are recurrent leakage, you can say, not rupture, but leaking of the endometrioma off and on in the different cycles lead to this kind of picture. So again, on the right side, you can see the whole of the tube here is such big, hematosalpinx here. So, and also appendix is being involved. So these are the girls, I feel that they require surgery because their pain has to be dealt and they will not respond to our medical treatment. So this was the end result after the surgery. The surgery most of the time is a fertility preserving surgery in which we try to preserve the ovarian reserve. We give them symptomatic relief by excising all the lesions in the POD. We free the POD, and this is the final picture in her. But I had to remove her this right side tube because it was totally and badly damaged. One tube was preserved on the left side. So surgical principles, I will not go into detail, but definitely laparoscopy or is minimal invasive way is better in them. Excision has to be done whenever you feel that you are doing laparoscopy, and if she is going for surgery, then definitely it should be a good excision surgery. Then all kind of preservation, whether it is nerve preservation or fertility preservation, should be should be given proper consideration before you plan your surgery. Should be should be counseled regarding it. And again, these are the two videos of surgeries, how we can preserve all the nerves and taking care of her fertility, how the ovarian reserve can be preserved. And of course, the option of fertility preservation should be given to these girls, and telling the possibility of using their own eggs in the future if they require. This other video is of the peritoneal disease, you can see here, but it was involving the ureter on the left side, which was causing hydroureter. So you can see here, these were just, spots, but we removed these spots because these spots itself cause a lot of pain in these girls. So these are so subtle lesions, peritoneal lesions. We call it peritonectomy or excision of the superficial lesions. And here it is not superficial. It was involving the whole ureter on the left side in this video, the laparoscopic view. And the ureter on the left side was stuck at the ureteric tunnel. Because if we leave these girls like that, they will land up, or they may land up in kidney failure, also kidney damage of that side. Now, post-op care is very much important. Why? Because if we operate at such a young age, though we avoid operating on them, and that is the purpose of detecting them early so that we can give them medical treatment and prevent them to land up in the later stages. But if by any chance we are operating on them, then we have to put them on suppression post-op as soon as possible, because we know that recurrence is something which we all are very aware is a common part of this disease. So again, in the suppression, we give them continuous post-op suppression with hormonal pills. I prefer Dynogest more because it can be continued for a longer period of time and it is safer. Then multidisciplinary approach is very much important in these girls because these are little girls, they are the growing age, their mental, this thing health gets disturbed because of all this. And they are associated with lot of, peer pressure and studies, and also a good psychology team, pain management is everything which should go hand in hand. And if they are on a long follow-up, it is good that you follow them with imaging as well as their symptom this thing recording. And you ask them to come initially every 6 months and then yearly. Now, these are the international guidelines which are just summed up here. All of them are agreeing on the main spatial thing. So some spatial considerations in adolescent endometriosis patients which are little different and which need emphasis is bone health, because this is the age where their bones and their growth is being has to be taken care of. So if you are putting them on any kind of hormones for prolonged like progesterone, then it is always recommended to add calcium, vitamin D, and if you by any chance starting GnRH, always add back therapy. Mental health, as I told you, these are the girls which needs lot of mental support from the family members and also from the friends and us doctors. Fertility preservation is a big concern in these girls because they may land up in repeated surgeries, and if the disease is missed and they progress, then definitely they may require their own eggs in the future. So fertility preservation is again important thing which need to be considered. So what should be the strategies to reduce this diagnostic delay? ACOG has come up with these guidelines that clinical diagnosis should be valid. One should not wait for laparoscopy, should initiate empirical therapy. Then one should have low threshold for referrals. If you believe that it is something which needs specialist care, should be referred. Then MRI is the diagnostic tool. A salivary test is coming, which can be used as screening test for these girls, but it has to be used cautiously. Multidisciplinary adolescent clinic should be there in all the hospitals, because this age is a confluence of pediatrics and adult specialists. And lot of programs should be there, awareness programs in the schools, which we are taking care also. So the key take-home messages in the end is treatment resistant to if the dysmenorrhea is resistant to your treatment, then definitely one should have high suspicion of endometriosis in this age group. Normal imaging does not exclude endometriosis, so don't wait for your scans or MRI to come positive to start your treatment, because diagnostic delay will definitely increase the disease burden in their reproductive age and later age years. Early recognition will reduce the surgical complexity also. Early suppression may preserve the fertility, because then some kind of anatomical damage will be it will be prevented because of this suppression. And always believe adolescent that they are suffering from some kind of problem if they come to you. Don't ignore it. Adolescent endometriosis is hidden, progressive. Timing absolutely changes the trajectory of the disease, as no disease progresses straightly to the stage 3 or stage 4. So in the end, endometriosis in adolescent is not rare. It is rarely diagnosed, and adolescent represents, according to me, a critical window where we can pick them and we can help these girls to land up in devastating condition later on. Thank you.
Wonderful deliberation, Dr. Sonu. I would request the chairpersons to give their inputs. Dr. Jaiswal, ma'am.
Okay. Sonu, your
Hi.
presentation was excellent, and you have covered all aspects. As we know,
the adolescent endometriosis is a difficult problem. Young girls comes with this problem, difficult to do the clinical examination, difficult to do the, even it does not come in the ultrasound and so many modalities also, but still the history is very important and most of the diagnosis can be made by the history.
Yes, ma'am.
On examination, you can do per abdominal examination, sometime per rectal also, because she may be married or not married, depending upon. And second thing is that in this, the treatment is very difficult because she's having such a agony. And for diagnostic, as we know, the laparoscopy is the gold standard, but in every woman we cannot do the laparoscopic examination because it's an invasive procedure. So whatever that we have to make the diagnosis on the basis of clinical and history and examination, we should start treatment as early as possible. And about the treatment, because she is in the growing phase, we cannot give even progesterone for the longer period because still there is a problem in the bone marrow density, bone density. So in that situation, we have to add calcium, vitamin D. So whenever we are keeping the patient on progesterone therapy for a longer duration, we have to give the ADVAC therapy. Second thing is that in this, as other endometriosis, making the patient amenorrheic for a long period or the 3 to 6 months, definitely it reduces the lesion and reduces the pain. Although the Dynogest is a very good drug which has come, and dydrobon or dydrogestrone is also coming in the market. Both are good, but we have experience with the Dynogest, even we have used up to the 2 years. So we can use, but the only main thing is that to make the life comfortable. Now come to the fertility preservation. In that, because this disease involved for fertility, because especially endometriosis, and if we are going to do the surgery, in that we have to do the AMH before going for the cystectomy because we don't know the result. So first we do the AMH, then do and it will help in the counseling also. So that is very important. And thank you so much. You have covered all aspects of, and your video is so wonderful. Nice. Thank you so much.
Thank
Dr.
you.
Raju, Dr.
Chairperson
Raju,
who wants to talk. Give
Dr.
opinion.
Raju, are you there? Dr. Raju?
I don't think so, ma'am, is there?
Okay, fine. Thank you, Dr. Sonu, once again, and Dr. Jaiswal, ma'am, for summing up the whole session so beautifully in a few minutes. Moving on to the session
Thank
2,
you.
we have yet another very esteemed chairpersons for this session. And the first chairperson, a very dear friend, Dr. Anjana Agarwal, ma'am. She's the professor and head obstetrics and gynae of Hind Institute of Medical Sciences, with 26 years of teaching experiences and her with special interest in infertility and urogynecology. She's a member of advisory board of PAJOG with number of publications in national and international journals, associate life member of AMASI and a lifetime member of ISOPAP, as well as being a member of LOG since 2000. The next chairperson for the series is Dr. Anubha Dudia. She is a private practitioner in Hapur, and at the present moment, she is the current secretary of the Hapur Obs and Gynae Society and a senior consultant and gynecologist of Anubha Multi-Speciality Hospital, as well as Nidan Nursing Home and Dr. Narendra Mohan Hospital. So she has a lot of hospitals which she's managing excellently. Her field of interest is high-risk pregnancy and infertility and is actively attached to many NGOs with a lot of social activities. So she's a woman who's multitasking in every direction. Welcome, Dr. Anubha and Dr. Anjana. The third chairperson is yet another very loving, caring. I can give her a number of fantastic adjectives, but that would take up my whole day. And Dr. Anshumala Rastogi, ma'am, she's at the present moment the treasurer of Lucknow Obs and Gynae Society, a very senior consultant of Obs and Gynae in ERA Medical Center, Lucknow, and she's been the treasurer for the recently conducted Art of Birthing Conclave in Lucknow. I would request any of the chairpersons to please introduce our speaker Dr. Neha Negi.
Hello.
Yeah. Yes,
Hello.
Dr. Anjana. Yeah. Hello, Dr. Anjana. Yeah, please go ahead.
Dr. Neha Negi is Associate Director of OBGYN in Apollo Bedick Super Specialty Hospital. She will talk on the adnexal masses in adolescent with evaluation and management. Please, Dr. Neha.
Thank you, ma'am. Good evening to everyone. Good evening to my seniors, and I'm extremely honored to have got this opportunity to speak on a topic of the age bracket, जो कि आजकल काफी हम लोगों को देखने को मिलते हैं, the adolescent age group. I'd like to share
Please
my
stop
slides.
sharing, screen sharing.
Right,
Tech
ma'am.
support,
I'll
please
do it.
stop screen share. Yeah, thank you. Now we have Dr. Neha with us. Yeah.
Ma'am, is my screen visible?
Oh, Dr. Neha, your screen is not visible.
Right.
If not, I can share your screen, but then I
Yeah.
will need screen sharing rights. Just check it out. If yours is visible, then it's fine.
Ma'am, I'll do that. Am I visible now, ma'am?
Yes, absolutely.
Yes.
Right? Okay. I'll make it the larger screen now.
Yeah.
Is that okay, ma'am?
Perfect. Absolutely. You're good to go, Dr. Neha.
Thank you, ma'am. So good evening to all my seniors, all of my teachers and guardians. So I move forward with the topic to discuss is the adnexal masses in adolescents. आजकल हमको इस age bracket के काफी ज़्यादा patients देखने को मिल रहे हैं. Pardon, ma'am?
That's okay. Dr. Monica has muted herself.
Right.
Please go ahead.
So I'll be covering the topics under the following headings. So going on to adolescent age group, basically they are the young girls of the age bracket of 10 to 19 years of age, which is one of the now thrust of because the awareness due to various diseases which is now coming up with the parents as well as the young girls. Now they are becoming aware of the pain, the irregularities to take and seek medical help. That is a good point. So these are the bracket of girls that we are now seeing as our young patients. So adnexa is anything which is attached to the uterus, that would be the ovaries, the fallopian tubes, and the ligaments attached to it. So the patient of the adnexal masses in adolescent may come to us with any of these symptoms. Many a time it is that she had a little discomfort and they got an ultrasound done incidentally, or usme they picked up a adnexal mass. So many a time हमारे पास patients asymptomatic incidental finding on an investigations आए, या फिर abnormal uterine bleeding which could be in the form of irregular periods or even post or premenstrual spotting may be there, abdominal pain which could be selectively a dysmenorrhea associated with the periods, or it might even be with or without the period cycle also. Abdominal distension, or at times the patient may come with a very short history, because here in the history holds a lot of key answers to making a diagnosis of an adolescent mass. If she has a short history of acute pain कि कुछ ही दिनों कुछ ही घंटे में बहुत sharp shooting pain उन्हें हुआ, or she might come with some urinary or GI conditions. So broadly speaking, whenever the patient comes to us with a history of abdominal mass or any chronic or acute symptoms, we can start thinking on the lines whether she is coming to us with some acute event like sudden onset pain, or a chronic long standing history of gradual pain more during periods. So if she is coming with an acute symptoms, we should keep in mind that it could be an ectopic pregnancy, or which is not rare now in adolescent age group also. So we must keep a track of the menstrual history in these patients also, or even a hemorrhagic cyst or a tumor mass, or even the non-gynecological being appendiceal or a diverticular masses. Or she might give a chronic condition like for many months and years she had had a progressive discomfort or a dysmenorrhea, as Dr. Sonu has elaborated on the endometriosis in adolescents, so it's not rare to have them now. So as a form of endometrioma, ovarian cyst, or a dermoid cyst. Rare, it could be torsion, but that is a medical emergency, but it may come up as a condition for us. So in broadly, if a lady comes to us, how are we going to evaluate it is that we could have any of these conditions with which the patient may come up with the problem of an adnexal mass. It could be of the ovarian origin, or it may not be from the ovarian origin. If it is not from the ovarian origin, it could be coming from a tube, or it might be a pedunculated fibroid even, or this. And in ovarian, it could be just a functional cyst that is limited to that very cycle, be it a follicular cyst or a hemorrhagic cyst, or it might be other neoplastic conditions also. So whenever the patient comes to us with an adnexal masses, so after a good amount of history taking, considering her onset of symptoms and a detail of her menstrual history, we must go in for a examination, like a general examination, the pallor, the general condition, and appearance of any tenderness that might happen there. Because in case of torsion of the ovary, or even a ruptured ectopic pregnancy, which might be seen in this age bracket also, so we might be able to detect it by doing a per abdominal examination. Also, if we are able to feel it, the tenderness, the mobility, the bilaterality of it is important. Then if possible, then we might do a rectal examination also, because that would give us a indication as to the uterine mobility, the type of the mass that we are feeling, or whether it is a unilateral mass or a bilateral one, and its consistency. So after an elaborate examination, a clinical examination, the first line of investigation is usually hello.
Yes, ma'am.
Ma'am, your
Yeah,
screen has stopped sharing. If you could please reshare your screen.
Okay, okay.
I think Dr. Neha has probably lost.
Yes,
Yeah,
connection
she started.
management. Yes, ma'am.
No, but this is.
No, Dr. Neha,
No,
you need to reshare
no,
your
Dr.
screen.
Neha has to start the screen sharing.
The tech team, please stop sharing.
Tech team,
Yeah,
please stop sharing.
yeah,
Yeah.
yeah. Ma'am, you can please share your screen.
Yeah, but I think Dr. Neha might have to rejoin because I
Acha,
don't think
okay.
she's there.
No, ma'am, she's there. Her video is off.
Should I call her? Because I have her presentation, so she can join even with her mobile. Can anybody call her?
I'm just giving her a call, ma'am.
Yeah.
Ma'am, if possible, ma'am can share their presentation to me so that I can able to share.
I'll
That
share
is
it
not
with
the
you.
issue. I have just asked her. She didn't know that she was disconnected. She's just joining.
अच्छा, okay, okay.
Because even I have a presentation open in front of me in case she has difficulties in screen sharing. Save your number. No, just a moment. There is no audio, Dr. Shubhangi, because Dr. Neha has got disconnected. That's why there's no audio.
Ma'am, am I visible now?
Yes, Dr. Neha, you're visible. Good,
Now
great.
you're
Is my
visible,
screen
ma'am. You can start your screen again.
right, ma'am? So is the screen visible, ma'am? No?
No, not as yet.
Ma'am, please start resharing.
Right, ma'am. I'll do that. Right, ma'am. Is it
Yes,
visible now,
perfect,
ma'am?
perfect.
Right. So as I said that the first challenge with us is making the diagnosis as to what type of a management we need for this patient. So the basic investigation and the first line is the ultrasound, in which we have certain classifications which help us to decide on the management for the patient. One being a unilocular simple cyst that we are getting, that would be a simple or a follicular cyst. Other, it could be endometrioma, which would be dealt. And second, if there is a small solid component in it, that could be a benign cystic teratoma. That's a dermoid that we are dealing in. If there are acoustic shadows, it goes more in favor with an endometrioma or a mature cystic teratoma. So these are, we are seeing a multiple smooth multilocular tumor, but the size being less than 100 mm would be more like cystadenomas, serous cystadenomas that we are dealing with, and the blood flow. So these help us to decide whether the type of adnexal mass, the type of the ovarian mass we are dealing with is benign or neoplastic. The M rules being the malignancy indicators would be irregular solid mass, having a situs, more, at least 4 papillary structures, multilocular cyst, and very strong blood flow if it is there. For wherein we have got it is to the tune of 90 to 95% that we have. So basically, the symptom constellation to redefine the diagnosis is a young girl, adolescent coming with an acute onset pelvic pain who on history is on some form of an anticoagulant. For being a cardiac patient, being a DVT patient, she is on anticoagulant. And on ultrasound, what we are seeing is a round ovarian mass with well defined, regular, thin walls, fibrin clots being seen in the CL with the solid septations, more in the favor of a hemorrhagic cyst. Then, if the patient is coming to us who on history has found to be amenorrheic and is having bleeding and in shock, so that means if on scan I'm seeing an empty intrauterine cavity, GSAC lying there, so it is a ruptured ectopic that we are dealing with. A patient who is coming in with a unilateral pain, off and on worsening pain that usually halka halka dard rehta hai, and then at times you have worsening of pelvic pain which is not getting corrected, so more in the favor of a torsion. So these are the pictures in correspondence with the clinical history and examination that we should keep in mind when dealing with such patients. Either she is coming with fever, chills, vomiting, discharge, we are seeing on scan endosalpingeal folds thicken. So that is more in favor of a teomas. Progressive dysmenorrhea, pain during periods, severe to the amount not being corrected by medications. So ground glass appearance we are getting on us, so more in favor of a endometrioma. So this chart helps us for the clinico-radiological correlation and making a sound diagnosis for the adnexal mass. Now, coming to the RMI scoring, that is a risk of malignancy index scoring, wherein this should also be done in patients whom we have a higher suspicion of any malignancy, wherein we take the ultrasound score, the menopausal status, and the C125 levels, wherein the high risk of morphology would be 3 and then 1, and we have the sensitivity of almost to the tune of 81%. Ultrasound features that goes in the favor of malignancy are multilocular cysts, those which are having solid component, or any metastatic component, ascites, or bilateral lesions go in favor of a neoplastic or a malignant lesion. So risk of malignancy indices over the period of time, we've got an RMI score 1, 2, 3, and now 4 that is there, according to which the cutoffs are laid down, and we take into consideration whether what type of an ultrasound finding it has, the size of the tumor, the menopausal status, and with these cutoffs to the sensitivity of 85%, we can predict the type of ovarian mass that we are dealing with. Now we come to the management as to the treatment. So simple ovarian cyst, as I had said, with the history and the findings on an ultrasound, we can make up a diagnosis. So if we are dealing with a simple follicular cyst and the size is more than 3 centimeters, incidentally diagnosed, it usually resolves 4 to 8 weeks with expectant management. We can only give her pain relief and NSAIDs and ask her to come post-menstrually the next cycle in 4 to 8 weeks signs, and most of the time these type of cysts will get resolved. If she is having a corpus luteum cyst, as in the period with anticoagulants or a bleeding diathesis, we need to correct the PTINR correction, and that would resolve the cyst again. A thecal lutein cyst that would happen in pregnancy, we need to look out for that, a beta HCG scores and the ultrasound findings for that. Coming to the paratubal or the parovarian cyst, this is around 10% of patients may have the parovarian cyst and the paratubal cyst. Now, these cysts are very difficult to treat because if we give them any hormonal management, then most of the time they do not resolve on its own. But if continuously the patient is complaining of pain and intermittently a worsening of the pain, so they might be going into torsion and detorsion, then we need to remove it surgically by laparoscopically for it to be corrected. So coming to the management of ovarian cysts in adolescents, the presentation of adolescent ovarian cyst may be asymptomatic, or they may come to us with pain or menstrual irregularities. We may do a transabdominal sonography for them. So if it's a simple cyst ranging from 3 to 5 centimeters, we can rescan in say 3 months time for reassurance. A premenarchal girl, we may review in the OPD. If it is a simple cyst of around 5 to 7 centimeters, and if it is more than 7 centimeters, then we need to consider certain things. Like if it is around 5 to 7 centimeters, if she is asymptomatic, we can keep her on oral contraceptive pills for 1 or 2 cycles and ask her to get a rescan in 3 months' time. It would mostly resolve. But if it persists, then we might go for tumor markers or an MRI, if even on medication, these cysts are not getting resolved. If it is more than 7 centimeters, then it is always better that you do a laparoscopic cystectomy with it, or thoda sa at times, because of the age of the patient, we may give it a trial for giving her of hormonal treatment for 1 month trial. And if it resolves in it good of a decrease in size, then we can continue the medical management for another 3 months. But if not so, a cyst more than 7 centimeters, it would be better to simply remove it by laparoscopy. Acute abdomen would go in the favor of torsion or rupture of cyst, simple ovarian cyst more than 7 centimeters, wherever there is a suspicion of malignancy and persistent cyst not responding to conservative medical management. These are the conditions wherein we should opt for surgical management rather than expectant management. Coming to the complex ovarian cyst, the most common type of a complex ovarian cyst that we deal in with the germ cell tumor, and that is mature cystic teratoma, a dermoid. Other complexes that we might see in this age bracket is an endometrioma, a gonadoblastoma, or a serous adenomas. The dermoid cyst being a mature cystic teratoma, the most common type of a benign ovarian neoplasm is found in this age bracket to the tune of 10% to 25%. So they are basically from the totipotent cells of the ovary, and 50% of pediatric ovarian tumors is dermoids. And around 10% of cases, they might be found in both the ovaries. Now, we must understand that they have a very high tendency of undergoing torsion to the tune of 46%. And in these patients, we should try and manage it this way, that surgical removal of the dermoid cyst is the option, because there is no medical management for the dermoid cyst. Coming to the management of the complex cyst, if you ever come across, when we do an scoring on an ultrasound, the IOTA scoring, and we find it's a complex ovarian cyst, that is the time when we should advise for a tumor marker or an MRI. If there is no suspicion of cancer, symptomatic more than 5 centimeters, go for and plan for laparoscopic cystectomy. But if there is malignancy, so then we move the investigations and treatment in that direction. Coming to the one of the most acute condition that we might face with adnexal masses and the ovarian cyst is ovarian torsion. It is sudden in onset, intermittent pain, non-radiating, and it is associated with nausea, vomiting, untractable pain, not responding to medications. So ovarian torsion is a medical emergency where we need to look into it and get it treated. It is the prevalence of adnexal masses in adolescent in ovary without a mass. Compared to adults, it is 46% that high. 64% of torsions are more of the right side because of the sigmoid. Now we come to how do we detect whether there is a torsion or not. So ultrasound would make it more specific up to the tune of 96%. Affected ovary would look solid, edematous, hypoechoic areas with hemorrhage and necrosis in it. There is something called as a whirlpool sign, which is very diagnostic of it because of the twisting of the ovarian pedicle, that we give it a whirlpool sign. Most consistent is unilateral ovarian enlargement because of edema and the vascular pooling. We would get that ovary to be more bulky and enlarged. As we could see, the whirlpool sign because of the pedicle which has been twisted. Doppler changes in the ovarian vessels is found in around 100% of cases of torsion. Early would be just the coiling of the ovarian vessels. In late, there would be a complete absence of perfusion. So we need to treat, time is important for these type of patients because we might lose the function of the ovary if we delay it over the period of time. CT and MRI, if possible, then we should do. Otherwise, ultrasound carries a good 96% sensitivity and specificity for diagnosis of ovarian torsion. So a patient of ovarian torsion, an acute event, we have there is no other treatment except for undergoing a diagnostic laparoscopy. In case the management is to detort the torsion which has happened, even if the ovary appears dark blue or black. That is very important to know. It is not the color of the ovary which decides us to detort it or to save the ovary. We should try to save the ovary as much as possible, and do a cystectomy in the same event if it has caused the ovarian torsion, and oophoropexy if you find a lengthened ovarian ligament, because then that would happen again. So a repeat torsion, it is always best to do a pexy for it. Torsion in the presence of a true ovarian cystectomy, the cystectomy be done at the time of the laparoscopy after detorsion. The absence of the cul-de-sac suggestive the torsion days have high. Only in case, as you could see, even in this picture, the vision of the ovary was very blue and black because of the torsion. But once it has been detorted and pexy and fixed, so the color of the ovary changes over the period of time. So we should try to salvage the ovary to as much as possible. The endometriosis, a very quick review of this because Dr. Sonu has already covered it in detail in the previous lecture. The incidence is very high in adolescents. As she said, 25 to 73% of adolescents may be suffering from it. They may come to us with the problem of dysmenorrhea, pain during period, or GI symptoms also. So there is a scope of medical treatment in the form of hormonal pills and the contraception pills, NSAIDs, Dynogest, even considering a levonorgestrel intrauterine system and GnRH agonist. Hormonal treatment, NSAIDs in the adolescent, dysmenorrhea, severe pain and or endometriosis associated pain, the first line of therapy is hormonal contraceptions or progesterones. It is important to note that certain progesterones may decrease the bone mineral density, which we should explain to the patient, the relative in detail. Laparoscopy in adolescent, confirmed endometriosis associated with pain not responding to the hormonal treatment. We should think on the lines of surgical treatment in these patients, because if we opt for a GnRH agonist therapy for them, it shouldn't be more than 1 year, and if taken, it should be associated with the combination of add-back therapy along with it. So the Dynogest trial that happened, the 2 milligram regime, it was found, why Dynogest and why not? It was found that 81% of participants experienced a reduction in the VASA score to the tune of 30%. And the BMD decreased in only 1.2%, that too partially recovered after 6 months. So it is very effective in treatment of endometriosis associated pain in the adolescents as well as in the adults. As adolescents are in a critical period of attainment of peak bone mass. So very important is the bone density that we need to talk of. So in these things, the quality of life has improved in patients wherein we had given the add-back therapy, be in the form of conjugated equine estrogens or norethisterone. So in the add-back therapy, we can give them norethindrone acetate, that is 5 milligram daily alone, or along with the combination with the conjugated estrogen. So that would take care of the bone mineral density, and the pain can be taken for by the Dynogest use. Coming to the surgical intervention, if the patient disease over the period of time is increasing or the severity is increasing, it is not being relieved by medical management, so we should opt and think on the lines of surgical removal. Surgical treatment is indicated in such patients only with the hands of an experienced surgeon, because the aim of the lap surgery or the robotic surgery in these patients is to remove all the present endometriosis, which should be performed that in one sitting itself. And we must always give them post-operative hormonal therapy in order to decrease the chances of recurrence. That is very important. Whenever in a young girl we are operating, we are doing a fertility sparing surgery, we must try to bring down the recurrence rate. By two ways only it could be done. One, a very complete surgery removal of all the stigmas of endometriosis, and adding up for the combined therapy, the hormonal therapy in the post-op period. Fertility is preservation. Of course, the ovarian reserve and the future fertility should be kept in mind while we are performing any type of surgery in them. Coming to the corpus luteal hematoma, the patient may come to us with a symptomatic sudden onset pain after going to gym or exercising a physical activity. It's acute onset pain, hemorrhagic cyst, only conservative management in form of OCs, correction of anticoagulant therapy. If not resolved and the pain increases or the bleeding is there or a hemoperitoneum, then we can go for a laparoscopic surgery for it, the removal of the cyst. Then there are certain Mullerian anomalies which may also present as an adnexal mass that we should keep in mind in these section of patients, because these are the girls in which menarche is happening. So in if on investigation MRI it is coming, so we can manage it accordingly and a surgical intervention may be needed in certain cases. So an ectopic pregnancy if diagnosed, as we all know, we need to manage it either medically or surgically. So with this, I would like to keep just a few things in mind. The fertility preservation in adolescent is very important, because age less than 30, we should keep in mind that we should turn out to have a management in which we can treat the patient as well as cure the disease to the maximum. So in a nutshell, I would say that the absence of any radiological evidence does suggestive of torsion does not necessarily exclude it. If you have a clinical finding of a torsion with the history of an persisting ovarian cyst, then you must take the decision to do a laparoscopy for in order to save the ovaries. The decision to operate be on the clinical grounds if symptoms are severe. For the endometriosis patient, the first line drug that you can provide them is with the Dynogest, but we should always keep in mind the bone mineral density and the preservation of the bone health for them. And if needed, a progressive dysmenorrhea, we should always think of Mullerian anomalies also, which might need certain surgical corrections. Thank you so much, ma'am.
Yes, Dr. Anshul, could we have a connection? Thank you.
Yeah, actually, a very, very nice and a lucid presentation by Dr. Neha. I think she has covered all aspects of the adolescent adnexal masses, ranging from the simple ovarian cyst to the malignant aspect. And we should really, when the adolescents come to us with pain and all, we should not just dismiss it as saying, oh, this happens, ye to hamare bhi hota tha. It should not be. We should take them seriously, and we should really have a low threshold for the diagnostic interventions and the modalities. We should not hesitate in getting an ultrasound done for that girl, and we should manage accordingly. I think a very, very nice talk, and I think very, very nice take-home messages. Thank you, Dr. Neha.
Thank you, ma'am. Thank you so much. Thank you, everyone.
The other chairpersons, Dr. Anjana, Dr. Anuvi.
The presentation was very good. Clinical examination having very good role. So we have keep in mind the best clinical examination, give best management to the patient, and secondly the ultrasound can help. As Dr. Neha said that in the case of the ovarian torsion, clinical examination is very important for salvaging the ovary. We should not dependent on the ultrasound. We should take the quick step for salvaging the ovary. Thank you very much, Dr. Neha.
Thank you, ma'am.
Thank you, Dr. Neha, Dr. Anjana, Dr. Anshumala. Do we have Dr. Anubha with us?
Yes, ma'am.
Yeah, Dr. Anubha, please.
It was a very nice presentation, very clear cut regarding the treatment and approach towards the adolescent girls for this.
Thank you,
Thank you,
chairpersons,
ma'am.
once again for your inputs, and Dr. Neha for the fantastic deliberation. Handing over to Dr. Monica for continuing with session 3.
Thank you, Dr. Nivedita. Thank you, chairpersons and Dr. Neha ma'am for an excellent talk. Yeah, with the session 3 will be taken none other Dr. MC Patel, sir, on records, always at your rescue. And our chairpersons for today's session are Dr. Akhilesh, sir, Dr. Deepshika, madam, and Dr. Seema Mehrotra. Can we have the CV slides, please? The next slide, please. Next one. Dr. Dwivedi, sir, previous slide, please. The tech team, yeah. Professor Dwivedi, sir, is a retired Army Medical College senior gynecologist with 30 years of experience. He's joined different medical colleges since 2001 and in 20 years teaching of undergraduates and postgraduates. He's also a member of various organizations, a member of the Ethiopian Society of OBGYN. He's attended various conferences as well as has a chapter on HIV/AIDS in a book and guidelines for postgraduate residents. He's published many articles. We welcome you, sir, for this talk as chairperson. Our next chairperson is the next slide, please. Dr. Deepshika Goel, madam. She had done her OBGY from MLN Allahabad. She's practicing in Hapur since last 30 years and she's the director of Nidan Nursing Home. We welcome you, ma'am. Our next chairperson is Dr. Seema Mehrotra, madam. She's a professor in the Department of OBGY at KGMU Lucknow, secretary of the Lucknow OBGY Society, also the secretary of the ISOPAB Lucknow chapter 21 to 24, member of the Medical Education Committee FOXY and the Safe Motherhood Committee FOXY. She is also the executive council member of the Indian Menopause Society. We welcome you, ma'am. And we request any one of you to please introduce Dr. MC Patel, sir. Akhilesh, sir, I can see you also. So please unmute yourself.
I am CV of Dr. MC Patel. Yeah. Can I take it? Hello?
Yes, ma'am, please go
Can I take it, ma'am?
Yes, ma'am, please go ahead. The tech team, can you please show sir CV? Yeah, thank you.
Dr. MC Patel, first of all, he is candidate for FOXY President Election 2026. So please vote everybody to him. And his FOXY uniform consist, instrumental and pivotal role, medico-legal, training and support for members, Vice President FOXY 2018, Chairperson Ethics and Medico-Legal Committee 2011 and 2013, Organizing Secretary AICOG 2017, Honorary Secretary State Organization of Gynecologists and Obstetricians of Gujarat in 2022 to 2025. He is Organizing Chairperson MMCon, VPCon 2018, Honorary Member, Honorable Member to FOXY, PNDT, Violence Against Doctor and Regulatory Cell. Government and Statutory Roles, PNDT, NIMC, Government of India 2015, Gujarat PNDT, State Supervisory Board 2005 to 9, National Managing Body India Red Cross Society 2019 to 2022. And in community and service, honorary surgeon, Red Cross Eye Bank collected 1,000 plus eye pairs services in medical camps in Northeast states under Dhanvantri Seva Yatra under NMO and Seva Bharti organized since 23 years. And services in medical camps in Jammu and Kashmir under Dhanvantri Seva Yatra under NMO and Seva Bharti organized since 6 years. President, Lions Club 1997 to 1998. And professional leadership, President AOGS, President IMA Ahmedabad, National President NMO, and Organizing Chairperson Vivekanand NMO CON. And बहुत सारी चीजें ऐसी हैं जो इसमें नहीं भी हैं, but he is a very good orator and very good teacher also. Thank you, ma'am.
So, should I go? Please let me share my screen. Is my screen seen?
No, not yet.
Yes, sir. Yes.
Is it seen full screen?
Yes, sir. Perfect.
Okay, fine. Thank you, madam, for kind words. Greetings from Statue of Unity, tallest statue of world, and we all are proud of that statue. Warm welcome all the delegates and wishing you a litigation-free practice. At the outset, I would like to thank all the societies who have joined this webinar and President and Secretary of respective society and Dr. Preeti and Dr. Seema Malhotra in particular for helping me for this webinar. I also thank all the President and Secretary of respective society who has given me a nomination for my election campaign for post of President Foxy, and due to their wholehearted support, I have secured highest number of nominations all over India. So I am very much thankful to all of them. And before I go to the subject, please endorse my candidature for post of President Foxy election year 2026. Election would be from 1st August to 10 August. My commitment is still there. Wherever you are, I'll be there. Promise to reach the unreached. So today's topic always at your rescue. Usually I start any of my talk with this question: is it worth discussing? Yes, and if it is yes, then why? Because medical litigations are increasing in number constantly and steadily, and unluckily we gynecologists rank first as far as this litigation part is concerned. Give me 1 minute. Yes. And ignorance of law can never be an excuse, because as soon as any act, any law, any ordinance passes in government gazette, it is presumed by law that each and every citizen of India knows that law. So ignorance of law can never be an excuse. Let us see. This is real happened case in state of Gujarat only. It was unbooked patient, investigated and treated by another gynecologist, came at 7 a.m. with labor pain. It was breech at perineum, delivered by assisted breech delivery. After normal delivery of placenta and membrane, she developed convulsions and sudden cardiac arrest. She was resuscitated well. Opinion and help from physician and anesthesiologist were taken. Patient was shifted to higher center for further treatment after giving primary treatment and stabilizing the patient. But during course of treatment at tertiary care center, patient expired after 4 days. Case was filed, notice was served. Allegation was we had been to normal consultation only, but doctor gave heavy injection in glucose bottle, so she delivered and developed convulsions and cardiac arrest. Inference held by the court was doctor has not bothered to remain present in the court even once. What this doctor did, he gave all the documents of treatment given to that very patient to his advocate, and he didn't bother to remain present in the court even once. And for any reason, that advocate didn't produce those records in court of law. So inference held by the court was that doctor had not produced any document about treatment given. So in this particular case, compensation of worth rupees 3 lakhs with cost with interest was awarded to relative of the patient. So with this carry home message is never rely upon your advocate totally. Be in constant touch of your advocate and give him inputs about medical grounds and literature about your case, both in favor and both in against. because a doctor is bound to produce record whenever asked by the court, and if he doesn't, then adverse inference might be drawn. And it was decided in this famous case of Srimati Darsini Devi versus Kamal Bhushan Jain in National Commission in this particular case. So we are bound to produce record whenever asked by the court. Let us see one more case. This is again a real happened case from city of Ahmedabad only. In this particular case, surgeon decides to operate upon compounder's nephew for tonsillectomy free of charge. Patient was nephew of his own compounder and he had to take no charge. It was in good faith, total free of cost. So he was not serious about record. So he didn't prepare any kind of record in this particular case. So surgeon decided to operate upon this patient for tonsillectomy free of charge. No case paper was prepared, and due to some anesthesia complication, patient died on the table and notice was served, case was filed, and documents were not at all ready because he didn't prepare any document related to this patient, and in that very case he lost the case. So proper documentation in any case is utmost required, and if you do not, then it would be a suicide as far as medical legal consequences are concerned. Let us see one more case. In this very case, C. Jaipal Reddy versus Padmini Veluri, it is very interesting case, and allegation on part of party was it was without valid consent, and form which was signed by a patient and relative, it was blank form, there was nothing written, and it was not informed consent. These were the allegation in this particular case. And one more particular allegation in this particular case, Dr. Padmini didn't inform anything about said operation of hysterectomy. Doctor has removed both fallopian tubes and ovary unnecessarily, despite alternative methods were available to treat such patient and to remove fibroid. It was case of fibroid. Patient has requested management of hospital to provide information related to operation theatre documents and copy of case sheet, but it turned a deaf ear to it. So documents were not provided to the patient. So complainant had one more allegation was that complainant had only one child and he was interested to go for IVF treatment, but now uterus is removed, both the ovaries are removed, so it has no option to go for even surrogacy also. So these were the allegation in this particular case, and in this case compensation was demanded very heavy, 1 crore and 25 lakhs and 25 lakhs for pain and suffering. But in this particular case, inference held by the court was, it was very clear that doctor didn't bother to reply complainant's legal notice also, because doctor didn't reply notice served by patient, and she didn't appear in the court even once in this particular case also. So court was very clear that doctor is very casual and she had taken signature on blank form. So court interpreted that if doctor has no time to explain patient about this wording written in consent paper, we presume that doctor had no time to take proper care of that very patient. And in this particular case, compensation of worth rupees 10 lakhs with 9% of interest was awarded in favor of patient. And it was only due to improper documentation or not bothering to replying the notice, not appearing in the court even once, and we are not producing any proper record. So in this particular case, carry home message is defense is the right of a person and one must utilize it. So if you have very important document in favor of your treatment given to patient very meticulously, the documentation should be complete and it should be well produced before court in time. And in this particular case, inference held by the court was consent is not mere piece of paper on which patient or relative has to sign, but consent is a very important document of your communication, of your counseling. Whatever you have communicated to the patient, it should be well documented in consent paper. Each and every point should be mentioned, and it should be signed by patient and relative. And once it is signed, it becomes a documentation of your communication. So consent is a documentation of your communication. Whatever you have communicated is documented in consent paper. But in all this situation, documentation is always at your rescue. So, and once you produce all those records in court of law, it becomes communication of your documentation. So records are always at rescue. So keep them up to date. What was done, nothing was neglected, and given treatment fully met with standard demanded by law and ethics, and it should be easily acceptable whenever offered in the court. Important bills are also part of your record: purchase of oxygen cylinder, defibrillator, ventilator, emergency instrument like ambu bag, and all emergency drugs. And not only purchase of oxygen cylinder, but bill of refilling of oxygen cylinder is also part of your record, and it is a very important document, because in this particular case, allegation on part of relative was when he suffered heart attack, oxygen cylinder in hospital were empty, and we were saved in this particular case only due to bill we could produce in court of law of refilling of oxygen cylinder just 1 day prior of this accident happened. Transfer of patient. Many a time we have to transfer patient to higher center, so it should be in time at proper hospital, confirm availability of bed, ventilator, OT, blood, and escort in the same ambulance, and handing over of the patient is equally important. But very important part is transfer document. So you have to give all the papers to the patient, and use of pneumatic anti-shock garment, and if it is documented, it shows your consent to save life of patient in condition of shock. So as far as transfer documents are concerned, you have to give all the details of patient in that very document: name of patient, date of time and referral, reason for referral, detailed condition of the patient, vitals when first seen, vitals when referred, history of comorbidity, operation details, and all the indoor case paper should be given to the patient. Whether she was transferred in ambulance, yes, no, and arranged by hospital or arranged by a patient or relative, accompanying by, patient was accompanied by whom. So it is to be mentioned, and all equipments, oxygen cylinder, monitor, pulse oximeter, syringe pump. So we should mention everything in this particular document. And monitoring detail during transit is equally important. If you have a monitor patient during transit, it should also be documented, and it should be handed over to the patient party. So this checklist of this document which we have to give to the patient party at the time of transfer, and preserve all the transfer notes which you have given to the patient. One copy should be with you. If at all it is required, you can produce in court of law which document you had given to the patient. But you have not to remember all this. Simply visit FOXI website. Under this FOXI uniform consent, there are 30 different concerns available on FOXI website with 3 medical legal experts: Dr. Nikhil Datar from Mumbai, Dr. Dilip Walke from Pune, and myself, Dr. MC Patel from Ahmedabad. We have prepared 30 different consent, and it is available on FOXI website. So at the time of transfer of patient, which kind of document should be given is also available on FOXI website. You can download and use in your day-to-day practice. And it is very obvious: good record is good defense, poor record is poor defense, and no record is no defense. And it has been my experience during my medical legal practice, we doctors are very poor as far as record keeping is concerned. So as far as our record keeping is concerned, our approach is just like restaurant model. So how any restaurant manages the cases: people enters, ask for service, service is provided, amount received, amount recorded, end of the story. In restaurant, this is the story, and in many of the hospital, the same story is there. So proper documentation is very much required. And which are the purposes of documentation? It shows your quality of care, which how you have managed your patient. It is shown in documentation. Coordination of care, patient safety, provides legal protection. So whatever you have done for that very patient, you can prove only by record. And it is also useful for research and continuous education program also. So let us see types of documentation of or record: clinical records, administrative records, and financial record. We have to maintain all these records in our hospital. As far as clinical records are concerned, they are related to patient's treatment given. Say, for example, OPD register, and under income tax rule, appendix 4 and form 3C, we have to maintain OPD register with this detail: serial number, name, registration number, professional services rendered, fees received, date of receipt, and remarks if any. So these columns should be there in our OPD register. As far as indoor register is concerned, serial number, date of admission and time, date of discharge and time, name of patient and address, sex, diagnosis, nature of professional services rendered, bill number and date, receipt number and date, and remark if any. And we have to observe all this record: case paper, outdoor and indoor, prescriptions, fully written with all the details. Document patient's non-compliance in outdoor patient also. Many times patient doesn't follow our instruction. We have to mention in that OPD case paper or in indoor case paper also, patient is not complying to our instruction. All other records like X-ray, sonography report, ECG, biopsy reports, and any certificate. If you have issued any certificate to patient or relative of the patient, one copy should be with you. It is also one good document in your favor if at all you have to produce in court of law. Opinion and not from other doctors. If you have involved other doctors in treatment, then their note should also be there, seen by Dr. So-and-so, his or her findings, advice, and whichever advice given by him or her. And if we have executed those advice, we can prove by nursing chart also. And notes of conversation and events. How we had talked with patient or relative should be mentioned in separate paper, because many a time after so many years or so, we have to face litigation and we cannot recollect all the conversation. So if this type of conversation are recorded separately, it is not to be recorded in case paper also, but in that very conversation, many important point may be there which could be useful in our defense. As far as consent is concerned, it should be well informed consent, and we have to preserve it. Refusal of consent is equally important point. So if patient has refused, we have to take negative consent. And if patient is not ready to give negative consent, then we can take consent from any co-patient or any visitor of hospital that before us it was explained to the patient and patient was not ready to give consent. But in this situation, we have to identify that very person who is going to sign this document with all its full details of address, mobile number, etc. And we have to explain him or her that if at all it is required, he should be there in court to favor us, giving his evidence that it was explained before him or her and patient was refusing to give consent. Sounds and video recording is also a valid consent, but as far as video recording consent, if you are going to have video recording consent, then it is a double-edged sword, because many a time important point you can miss, and prosecution advocate smart enough to point it out that you didn't explain this, you didn't discuss this. So even if you are going for video recording, then also copy of consent paper should be on your table, and you will see that no important point is missed at the time of counseling and documenting in that very record. So not tampering of record with a later date, because any retrospective entry should be clearly marked, because if at all you have altered this record, then it gives you loss of credibility in court of law. Proper operative note, anesthesiologist note, it is very much mandatory, and there should not be contradictory statement between operating surgeon or treating doctor and operatives anesthesiologist note. Some other register we have to maintain: OT register, autoclave register, UV sterilization of OT and labor room and ICU, IUCD register, female sterilization register, birth, death, and stillbirth registration, that is register, blood and blood product transfusion register. One more area, non-compliance. Many a time patient doesn't follow our instruction, and it becomes a good defense in our favor, because it is a contributory negligence on part of patient. So we have to document that also. Say, for example, if we have advised patient to come for follow-up on particular date and patient didn't turn up, document it. If we have advised to go for blood sugar and if patient has not get it done, document it. Didn't take insulin as advised, document it. Didn't maintain fetal movement count as advised, document it. So we have to document this type of things. Many times you will be observing in your OPD also, the person accompanying the patient will complain. Doctor, she is not taking medicine properly. She is not taking proper diet. She is not taking milk. So make a habit to enter into record. Patient is not taking medicine properly, history given by mother-in-law. So this type of simple sentence becomes good evidence in your favor, good defense in your favor, because it becomes contributory negligence on part of patient. Some do's and don'ts about documentation as far as indoor case paper is concerned. Continuation sit should be named and numbered properly, because many a time very important page is missed and you may be in trouble. So there should be numbering. Handwriting should be legible. You should be able to read and decipher even after years, and not only an issue of aesthetic but becomes an issue of ethics, at least, or maybe an issue of life and death sometime. No abbreviation, because court is not happy with this type of abbreviation and court is angry many a time. Say, for example, PID. We considered it pelvic inflammatory disease, but orthopedic surgeon will consider prolapse intervertebral disc. SCOPV, something coming out per vagina. So this type of abbreviation should not be entertained in a case paper. Include sufficient details of examination finding in progress note, because in indoor case paper we have a habit to visit patient, but many a time either we do not enter into indoor case paper or we enter very casually. Let us see one example. Post-operative LSCS, GC fair, vital stable. 12 hours after operation, GC fair, vital stable, patient anemic. 16 hours after operation, pulse feeble, BP not recordable, patient saved after several transfusion. So one has maintained this record, but it are not up to mark, and this type of record are not taken into consideration in court of law. So at least we should have this type of findings in our record. Post-operative monitoring should include pulse, SpO2, temperature, blood pressure, palpation of uterus if you are dealing with antenatal patient before delivery, vaginal bleeding, if at all there is history, then we have to mention about intake and output also. So we have to maintain with all this vital data perfectly as far as our record keeping is concerned. Visit your indoor patient regularly and make a habit to enter into indoor case paper. Always keep copy of discharge card. Whenever you are discharging any patient, discharge card is a very important document, and it is a face of your hospital in society, which kind of treatment you have given to the patient. Give proper instruction to the patient at the time of discharge about diet and medicine to be taken, about exercise, follow-up, and references. If at all you have advised to consult any other consultant, then you have to mention in discharge card. It is very important part because in this particular case, it was preterm labor. Baby was admitted in NICU, but during admission and at the time of discharge, because in due course, baby was discharged from the NICU. Nobody has advised parents to go for opinion from ophthalmologist to rule out retinopathy due to prematurity. And in due course, baby went blind. Case was filed and compensation of worth rupees 1.8 crore was awarded in favor of patient, 1.73 crore by state of Tamil Nadu because it happened in government hospital of Tamil Nadu, and rest of the amount to be paid by NICU doctors. So in this particular case, particularly luckily, gynecologist was not made party. Only NICU doctors, that is neonatologists, were made party. So proper instruction at the time of discharge card is very much important. As far as discharge card is concerned, I don't want to go into detail, but all the details we have to mention in discharge card. As far as administrative records are concerned, we have to observe all the records related to certain laws and act. So we have to maintain all hospital records very nicely. PCPNDT, MTP Act, ART Act, Surrogacy Act, whichever practice we are doing, we have to maintain all the records accordingly as far as these acts are concerned. As far as PNDT register is concerned, there are only 4 columns: serial number, name and address of patient, name of husband or father, and date on which first reported for such kind of test. So this register is the only register in PCPNDT Act, and we have to maintain it very properly. There are some forms also we have to maintain. Form D for Genetic Counseling Center, Form E Genetic Laboratory, Form F as far as Sonography Center and Genetic Clinic is concerned. And if you are dealing with any invasive procedure, then Form G, it is again prescribed form, and we have to maintain this Form G, and we have to take signature of patient in Form G. This is also part of your record. This kind of board we have to display at conspicuous place, that is in waiting area, and we have to write name of hospital, address of hospital, and very important lining like this: sex determination of fetus, boy or girl, is not done here. It is punishable offense under PC and PNDT Act 1994. And asking for sex determination of fetus is also an offense under PC and PNDT Act 1994. So you can put it in your vernacular language, and in English it is very much must. This is a specimen of board which is displayed in my hospital in waiting area. Copy of PCPNDT Bar Act is also part of your record. You are under obligation to have copy of PCPNDT Bar Act, and on demand, you have to give it to any visitor of your hospital for perusal. There are certain different forms as far as MTP Act is concerned. Form A, B, C, D, Form 1, 2, 3, and Form E. Form A is form for asking for registration of center. Form B, if you are registered, then it is a certificate of registration. It is to be displayed at conspicuous place. Form C is a prescribed form of consent. You have to take consent in Form C. It is very much mandatory under PCPNDT Act. Form D, it is a consent by medical board. If you are dealing with a case of more than 24 weeks of pregnancy termination, then opinion from medical board is required, and medical board will give opinion in prescribed form, Form D. Form 1 is opinion up to 20 weeks of pregnancy by one registered medical practitioner. Form 2 is prescribed form of report which we have to submit monthly at the end of month to appropriate authority. Form 3 is register, or we can call it MTP register, or Form 3. So in this particular, all the details of patient we have to enter, and once number is given in that very register, all other correspondence we will have to do with number given to the patient and not with name. Form E is again one more form when you are dealing with termination of pregnancy more than 20 weeks and less than 24 weeks, then in this form opinion from 2 registered medical practitioners should be there. As far as financial records are concerned, bill book, invoice, receipt book, cash book, bank book, ledger, voucher book, salary register, staff attendance register. You can maintain it on computer also, but all these details should be there with you in your hospital. As far as good records are concerned, they should be clear, correct, comprehensive, chronological, and contemporaneous. So do not alter record because it leads to loss of credibility in court of law. Maintenance of record you can have on paper, on dictaphone, on computer, or any other media. And keeping indoor papers file month-wise according to serial number and scanning of all indoor case paper and preserving it on hard disk with adequate data backup should be used. And for how much period we have to preserve all this record? By law, PCPNDT related records 2 years, MTP related records 5 years, ART 10 years, and then after transfer to National Registry, as far as surrogacy part is concerned, for 25 years. By guideline, OPD for 3 years, indoor case paper for 5 years, guideline by NMC. As far as income tax related papers are concerned, for 10 years, CPA for 3 years, pediatric group of patients, that is our obstetric cases, for 18 plus 3 years. Because after attaining majority, patient may sue, so we should be keeping all the records related to our obstetric patient and delivery records up to 21 years. Keep meticulous record and preserve them at least for 7 years as far as CPA part is concerned. As far as registers are concerned, birth register we have to maintain lifetime, death register we have to maintain lifetime, and MLC till final disposal of decision, not lifetime, but final disposal of case. But in this situation, when we win the case, patient may prefer appeal in higher fora. So till final disposal up to Supreme Court, we have to preserve all the record. Keep originals with you doing all the correspondence. You have to give Xerox copy or computer copy to the patient. For more case, in this particular case, just I mentioned prior also, in this particular case, there was contradiction in a note of gynecologist and anesthesiologist. In gynecologist note, she had mentioned that vitals were within normal limit, and in anesthesiologist note, he had mentioned that vitals were compromised. So there was contradiction, and court didn't consider record, and case was decided against doctor. There are some important tips as far as record keeping is concerned. Clinical findings of consultant and nursing staff should also correlate, because your findings in your case paper and same findings in nursing chart should match, because if it doesn't correlate, then it could be troublesome to explain to the court, and it becomes a difficult one. After discharge, treating consultant should personally check all the papers. They should be well in order. As far as giving records, many times patients or relative of patient or insurance agents ask for a record. So permission of patient is very much must in this type of situation. Either patient herself can ask record, or she can give authority to any other person to collect record from hospital. As far as how to destroy hospital records are concerned, because many times we have no place to space to preserve all the record, and we have to destroy those records time to time. So there is a procedure. We have to give notice in 2 newspapers, one in English and one in vernacular language. And you will give notice like this: we are going to destroy record of hospital from this date to this date. Any eligible person who is interested to take or ask for any record, they may contact hospital before this date. After this date, all this record will be destroyed, and hospital will not be responsible for any record. You can destroy record by trading into pieces. You cannot give it to kabadiwala or pastiwala, because all these records should be destroyed very properly. So to conclude with carry home messages, legal principle is whatever is not written on paper is not actually done in real. So whatever we have done for our patient to save life of patient, it should be well documented. And medicine principle is very clear. Prevention of any disease is always better than cure. And same way, medical legal principle is have an excellent communication with your patient that cuts down the risk of litigation by 80% and let your sound paperwork tackle the remaining 20% of the cases. So all the best, have some basic legal knowledge and always obtain medical legal advice whenever you are in doubt. So if you want to sleep like this, take tender care of your patient. Pray Almighty God before going to sleep. Keep proper documentation and record keeping with all your patient OPD as well as indoor, and keep my visiting card below your pillow because I am always there to assist you in any odd given situation. If ever you need me, I will be just round the corner. So to conclude with my humble appeal to endorse my candidature for post of President Foxy election year 2026. So please vote and canvass for me. Election would be from 1st August to 10 August, 5 p.m. So with regards, salute to all. Thank you very much. Please do not assume. Please ask if any query, any question, if time and chairpersons permit. Thank you very much. Any chairpersons for your expert comments? Akhilesh sir?
Neha ma'am is there. Anjana ma'am, Neha ma'am, Akhilesh sir.
Akhilesh sir is there. Please unmute. Akhilesh sir, you are muted. Please unmute. Deepshikha madam, Seema madam, you can have your concluding remarks and then we can switch
Hello.
over. Yes, sir. Welcome.
Can you hear me, sir?
Yes, you are.
Am I audible?
Oh, yes, you are audible.
Thank you, sir, for nice presentation and about record keeping in the hospital and any healthcare units. And we are coming here and so I think this does not have too many medical legal problems, and the credit should go to you, and we are for you in the president election, and you must
Thank you,
win.
sir.
Thank you very much. God bless you. We are for
Thank
you.
you, sir.
Thank you very much.
Oh, yes. Thank you, sir. You are always with me. Thank you, sir.
Thank you, sir. Thank you.
Welcome. Any other chairperson, or we can conclude this session?
Deepshikha ma'am is there. Deepshikha ma'am,
Yes.
if we would like to take
Yes,
your comments.
Deepshikha madam.
So
Ma'am
there
is
is,
there.
yeah, I am here. So,
Yes, sir.
sir has always, sir हमेशा ही ये बताते रहे हैं कि records, how to keep the records, and there is no doubt कि we have learned so much from him कि he may tell us more about the topic, but we can't comment anything. It's a very nice lecture, and we are learning from him from time to time. Thank you, sir.
Yes. Thank you, Deepshikha madam. Thank you for nomination from Apur for my
Ji.
election campaign. Thank you, madam.
Thank you. Thank you, Akhilesh sir. Thank you, Deepshikha ma'am. Sir, I think we'll move ahead with the panel discussion.
Oh, yes. Straight.
Yes. So we have a very important, thank you once again, sir, for that very important lecture for all of us in our day-to-day practice. We will move on to the panel discussion. We have a panel discussion today on abnormal uterine bleeding across the reproductive lifespan, adolescence to old age. The moderators for the day are Dr. Monica Agarwal ma'am and Dr. Varda Arora ma'am. And the expert for the session is Dr. Uma Singh ma'am. Dr. Uma Singh ma'am has been the past president of the Lucknow Obs-Gynae Society. She is a senior technical director at University of Manitoba, ex-HOD and Dean of KJMU Lucknow. Welcome you, ma'am. Our moderators are Dr. Monica Agarwal ma'am, who is a professor in Obs Gynae at KJMU Lucknow. She's an additional professor. She has been the joint treasurer of Lucknow Obs Gynae Society and joint secretary of ISOPARM as well. Welcome, ma'am. Our second moderator for the day is Dr. Varda Arora ma'am. Ma'am is a senior gynecologist practicing at Lucknow. She is also an IVF specialist and laparoscopic surgeon, director and senior consultant and IVF specialist at Valencia IVF and Kidney Care Center, Lucknow, and the joint secretary of the Lucknow Obs Gynae Society. Welcome, ma'am. We have 8 panelists with us today. Firstly, we have Dr. Nishi Singh. Dr. Nishi Singh is the secretary of the Faizabad Obs Gynae Society. Welcome, Dr. Nishi. Then we have with us Dr. Kanchan Prasad ma'am. Dr. Kanchan Prasad is one of the senior gynecologists practicing at Moradabad and professor at TMMC and RC Moradabad. Welcome, ma'am. Then we have with us Dr. Renu Bansal ma'am. Dr. Renu Bansal ma'am is the past secretary of Hapur Obs Gynae Society and doing past private practice with an immense experience of over 30 years. Welcome, ma'am. Then we have with us Dr. Richa Pandey. Dr. Richa Pandey is also an associate professor at Saraswati Medical College at Barabanki. Ma'am is also the ex-consultant at District Hospital Barabanki. Welcome, ma'am. Then we have with us Dr. Sonam Rastogi, ma'am. Dr. Sonam Rastogi is the secretary of the Moradabad Obs Gynae Society. Welcome, Dr. Sonam, ma'am. Then we have with us Dr. Shailaja Bhamri, ma'am. Ma'am is the associate professor at Hind Institute of Medical Sciences at Barabanki. Welcome, ma'am. Next, we have with us Dr. Neha Chandra, ma'am. Dr. Neha Chandra is a vice president of Moradabad Obs Gynae Society with over 12 years of experience, a special interest in infertility. Welcome, Dr. Neha. And last but not the least, we have with us Dr. Richa Agarwal. Dr. Richa is an obstetrician, gynecologist, and fertility specialist and has been practicing in Moradabad for over 10 years. She was also my junior at KEM Hospital. So welcome, Richa. Over to you, Monica ma'am and Varda ma'am. Looking forward to an excellent discussion.
Thank you. So before Monica and Varda start the panel discussion, I just want half a minute because my flight is going to start. As you can see, I'm sitting here. I want to compliment Dr. MC Patel for organizing such wonderful webinars, which have got such relevant topics that everybody is interested. And I think hats off always. Nobody can compete with him about the, aspects. I'm sure Varda and Monica would make it so interesting and so knowledge compact filled with it that in the end you won't need experts. However, I want to congratulate everybody and my best wishes to Dr. Patel. Thank you so much.
Thank you, madam. Thank you.
Thank you, ma'am. Over to you, Monica ma'am and Varda ma'am.
Thank you, ma'am. Thank you, ma'am, for your best wishes. And thank you, Patel, Dr. Patel, sir, and Dr. Preeti, ma'am, Dr. Seema, ma'am, for having given us the opportunity to be a part of this webinar. And it is extremely honorable moment for us. So I think, Dr. Monica, may I go ahead with the first case?
Yeah,
As
please,
per,
please. Yeah.
Okay. So we already studied a lot about endometriosis and adnexal masses, and we have an excellent, enthusiastic panel. So we would move ahead with the first case, which is a case of adolescent abnormal uterine bleeding. So she's a 13-year-old girl. She comes to our OPD, as routinely we come across. She is having continuous moderate painless bleeding from past 2 to 3 days. The periods are irregular, they are heavy, and she had menarche 6 months back. There is no history of bruisability, epistaxis, gum bleeding, and there is no significant personal or family history. She is not sexually active, as she said. And on examination, her vitals are stable. There is mild pallor, no petechia, the weight is optimum. Per abdomen findings are non-significant. PSPP was not done. So with this, we come to what is abnormal uterine bleeding. I'll just share with you in short, because as we need to know the background. Abnormal uterine bleeding is defined as bleeding from the uterine corpus that is abnormal in duration, volume, frequency, and or regularity, and because due to immaturity of the hypothalamic pituitary ovarian axis. So thus the perception of normal menstrual cycle may vary in these girls and their families. So we need to understand what is normal and what is abnormal. So any menstrual cycle between 21 to 34 days lasting for 7 days or fewer with an average blood loss of 30 to 40 ml leading to 3 to 6 pads or tampon per day would be considered as normal. So now what is heavy menstrual bleeding, which is a common form of abnormal uterine bleeding is defined as excessive menstrual blood loss that interferes. So here we are not talking about the quantity. It is any amount of menstrual blood loss that interferes with a woman's physical, social, emotional, or material quality of life. Some additional findings might include frequent pad changing, tampons more than every 1 or 2 hours, use of double hygiene protection, frequent soiling of clothes or bed sheets, and blood clots more than 1 inch to 0.5 centimeter in diameter. So this is how we go about it. So my first question to my esteemed panelist, Dr. Nishi, what are the causes of abnormal uterine bleeding in adolescent girl, which you usually come across? Dr. Nishi? Am I audible?
I think she's not there, so anyone else can take the question.
Anyone else can take the question?
Yes, may I answer?
Yeah, sure.
Okay. Then in adolescent, mostly.
Can you be a little louder? Yeah.
Am I audible now?
Yeah. Thank you.
In adolescent, mostly this irregular type of bleeding, the reason is ovulatory. And ovulatory cycles are very much common in adolescent and perimenopausal age group. So we will think of it. And other causes may be we have to rule out the pregnancy. We have to rule out the endocrine disorders. We'll have to get the serum TSH done and prolactin done. So we should also keep those in mind. And if there is history of very heavy menses since the onset of menarche, then we'd also think about the coagulopathy after taking a proper history.
Yeah, very rightly said.
Structural causes
So
are
the most
usually
important thing which we
not
need
very
to see
common.
is that ovulatory dysfunction is the most important cause of abnormal uterine bleeding, because it takes around 6 months to 3 years for the hypothalamic pituitary axis to mature. So one should not get panicky at the first episode. And the other causes, obviously, we need to rule out. So as far as this patient was concerned, what will be your approach? Obviously, going with the history taking, proper clinical examination, investigation, and then reassurance and counseling. So what are the investigations required in this case? Do you routinely go in for coagulation profile? Dr. Kanchan, are you there? Dr. Kanchan?
Can I answer?
Yeah, sure.
Ma'am, usually in adolescent age group, in all the patients, we don't go for coagulation profile testing. So she should be having some history of recurrent bleeding episodes like episaxis, gum bleeding, or bleeding from any injury sites. Or she might be having a history of heavy menstrual periods lasting for more than 6 to 7 days, and frequent change of pads, clotting. Then there should be a strong family history in which the family, any of the family members might be having a history of PPH or any surgery after deliveries, hysterectomy. And these are few history which are important, and only then we should go for coagulation profile testing in such patients.
Very rightly said. Routine coagulation profile is not recommended in a case of AUB, but there are certain indications which you have very rightly shared. So now, in adolescent and with abnormal uterine bleeding, coagulation profile is not required in every patient. Only with patient in whom we are having a suspicion of coagulative disorders. So this is as per the committee opinion for adolescent. And with this, we come to the second question. Okay. So what about the hormonal profile? Do you go in for hormonal profile in all the cases, Dr. Renu?
Yes, sir.
And what are the hormones you are advising in such cases?
Good evening, everyone. While evaluating the adolescents with AUB, we should consider some points. After ruling out the pregnancy, first and foremost, easy detectable cause, we can go for the hormonal changes if it is negative, hormonal causes if it is negative. And the most of the time, the cause is physiological and anovulatory cycles because of the immature hypothalamic pituitary ovarian axis. The first two basic investigations done after taking proper history and the clinical examination is thyroid profile and the prolactin level. Thyroid profile, because it causes both hypo and the hyperprolactinemia, causes menstrual irregularities and ovulation. And if the galactoria is also present, the prolactin level means a lot with this. Now, if the patient is having acne, hirsutism, obesity, or the persistent oligoamenorrhea, then we have to advise testosterone level. And in this, the free testosterone level has more specificity, sensitivity than the total testosterone level. If the patients have the virilization, male-like baldness pattern, severe acne, reduced breast size, there is deepening of voice, and if there is rapidly progressive hirsutism, then we should advise DHEA level and the 17-hydroxyprogesterone level to rule out, to compare it with the non-classical CH. The other test, routinely we don't advise, but if there is a amenorrhea, delayed puberty, and there is suspected ovarian insufficiency, then we advise the FSH estradiol level also.
Okay, very rightly said. So hormones, we should not go for the whole hormonal profile. Yes, TSH is very important, and we should go in for TSH levels. But routine prescription of prolactin and LH, FSH is not advisable. What you need to go in for, yes, we need to assess the routine hemogram, the ferritin levels, and the coagulation profile if there is suspicion, beta HCG to rule out pregnancy, and if for every adolescent abnormal uterine bleeding case. But if there is obesity, acne, hirsutism, so in those cases you can go in for testosterone, free testosterone, prolactin, all these cases. And if there is amenorrhea, then obviously FSH, estradiol, prolactin. So what about ultrasound? Dr. Richa, is pelvic ultrasound advisable in all the cases? Do you advise it on the cases of abnormal uterine bleeding? And
No.
in which cases do you specifically prescribe pelvic ultrasound? And
According
why?
to me, the pelvic ultrasound will not be recommended in all the cases. Like most of the times, it is due to the anovulatory cycles, and some hormonal abnormality may be detected in the patient in the first go. So we should not go immediately with the ultrasound. We should first observe and undergo other tests, as we have already discussed earlier, like CBC and hormone profile, thyroid, prolactin, and all these. After that, if required, and if we are suspecting any organic disorders like palm, part of the palm queen, then we should go for an ultrasound in these patients.
Very
Even
rightly
ACOG
said, Dr. Richa,
recommends
because
the
usually
same.
structural abnormalities are not the causes of abnormal uterine bleeding in adolescent females. So at the first go, prescribing an ultrasound, pelvic ultrasound is not recommended, only in those cases in which you are suspecting a structural abnormality. And also cases of failure of medical therapy. You can enumerate, Dr. Richa, you can go ahead with it.
Yes, in cases of failure of medical therapy, like persistent bleeding is there, if there is a recurrent AUB despite therapies, then we should go and get an ultrasound done. Secondly, if there is a suspicion of some structural causes like palm, part of the palm-Cohen classification, that is enlarged uterus, any pelvic mass or distorted pelvic anatomy, then we can go for an ultrasound. Thirdly, if there is severe dysmenorrhea, unilateral plane, and adnexal tenderness is there, then also we should go for an ultrasound in these cases.
Yes, very rightly said. And we have already had a detailed talk on the adnexal masses. So these are the indications wherein you would go for an ultrasound. So coming to the palm coin classification, any one of you, Dr. Shailja, are you there? Can you just elaborate what is the palm coin classification and how is it significant in this case?
Yes, ma'am. The palm coin classification is actually an acronym which divides the causes of abnormal uterine bleeding. The palm part of this gives the structural causes and the coin part gives the non-structural causes. The structural causes are polyp, adenomyosis, leiomyoma, and malignancy and hyperplasia, whereas the coin stands for coagulopathy, ovulatory dysfunction, endometrial disorders, iatrogenic, and not classified causes. So this comes in the FIGO system 2 of classification.
Very rightly said. So the as per the palm coin classification, this females fall in the AUB-O category. So the investigations were done in this 13-year-old girl, and the lab findings came out to be the hemoglobin was almost in the just borderline 10.5 gram%. Thyroid profile was normal. Coagulation profile was normal. Ultrasound was also normal. The only finding was mild anemia. So what's your impression and how will you manage this case? Dr. Sonam, are you there?
Yes, for the mild cases, the most important thing for adolescents is to counsel them and reassure them.
Yes.
They have to maintain the menstrual diary for 2-3 months, and iron should be given to them. Oral iron supplementation is very necessary. As we got the CBC, hemoglobin is in mild anemic range, and we'll observe for some more time because that is mostly anovulatory. In some time, HPU axis will mature, and it will take a few months to get proper ovulatory cycles, and the symptoms may resolve.
Oh, very rightly said, Dr. Sonam. So had this patient was a case of moderate AUB, then what would you have done in such a case?
If she
would
is
you
there
advise progesterone pills or COCs?
We'll prefer COCs because it
Okay.
will be containing estrogen. Estrogen is better for regeneration of the endometrium.
Yeah.
It will
And you
regenerate the
go for
denuded endometrium.
monophasic COCs, no?
Yes,
so how do
yes.
you prescribe COCs in a patient with AUB in an adolescent girl?
The COCs containing the high amount of estrogen. Like if there is heavy bleeding, we can start with 50 microgram. If it is not that heavy, then 30 microgram containing. And the fourth-generation progesterones like levonorgestrel and norgestrel, the combination with ethanyl-esterol, we can start. If there is
Supposing this
heavy,
patient comes with severe anemia, active heavy bleeding, then what would you do?
if she is coming with severe anemia and active bleeding, so first we'll see her vitals if she needs to get stabilized first, admitted or stabilized. And then we can give high doses of estrogen to her. Then COCs containing high estrogen, we can give, first we can give for 6 hourly. If there is very, very heavy bleeding, then when we can taper to 8 hourly, then 12 hourly, like this.
And then you can gradually taper it down.
Yes. But first we'll
Because
have to
these
control the
adolescent
active bleeding.
girls are very they respond very well to COCs, and very rarely they need blood transfusion. So this is one thing which should be kept in mind. And blood transfusion is especially indicated when there is hemodynamic instability, severe symptomatic anemia, or significant blood loss. These are as per the ACOG guidelines. So what is the management if you suspect a coagulative disorder?
Are you asking me? Okay. Are you asking me? Okay. If we are suspecting the coagulation disorders, then we'll use the we'll use the fibrinolytic agents like tranexamic acid. And
Achha, do you use NSAIDs in patients of AUB?
Yeah, we can give.
I'm asking to all the panelists, do you use?
Yes.
Can be associated if it is associated with pain as well, and she
Yeah.
is
So you
having
have to be
HMB
little
along with.
cautious when you use it with when you're suspecting a bleeding disorder, because in such
Then
cases
we'll
you
avoid.
cannot.
Yes.
Yeah, you
Yes.
have to avoid.
Only.
Then we'll avoid.
Okay, so the preferred treatment in cognitive disorders will be tranexamic acid. You can combine it with hormonal therapy, but there have been papers which suggest that if you combine it with hormonal therapy, then there can be thrombotic events, but rarely 25-year data has not shown any such event. So with this, are there any indications of surgical procedure in such cases?
Yeah.
The surgical procedure is rarely required in these cases because more likely they are anovulatory or some hormonal imbalances there. So it's better to observe and try the medical things better before. But if surgical procedure may be required only if there is a failure of medical management, or if the patient is hemodynamically unstable, or if she is likely to be urine pregnancy test positive and she has some retained products or some structural pathology is there, then only we'll go for surgical management. Otherwise, it's better to go for a medical management and treat the patient accordingly.
Obviously, definitely you'll go in for only in cases where there's hemodynamic instability or suspected retained products. So, a role of tranexamic acid. Anyone? How often are you using tranexamic acid? Are you using it in combination with mefenamic acid, or are you using it in only as any one of you?
Ma'am, tranexamic acid is usually used as a first-line agent when an adolescent girls come with abnormal uterine bleeding, that is heavy menstrual bleeding, and it is used with mefenamic acid only when there is severe pain or other symptoms like that. And tranexamic acid significantly reduces blood loss up to 30 to 50% in most cases, and it is a non-hormonal therapy, so it does not have those side effects. It is anti-fibrinolytic agent. It blocks the conversion of plasminogen to plasmin and helps to retain the clots that have been formed in the blood vessels. So first, tranexamic acid is used, and it can be combined with hormonal pills
At
for
what dosage
management.
are you using, Dr. Shelja? At what
Yes, ma'am.
dosage are you
Pardon?
using? You are using 1000, or what is the maximum dose which we can use in such patients?
Ma'am, it is 1300 mg. And it has to be given it can be given 2 to 3 times daily.
Yeah, usually we are more comfortable with, I think, the 500. We can even give it 2 tablets a stat. Nowadays, we have the 1000 milligram preparation also, 1000 milligram preparation in IV form also. So you can use it in active bleeding cases, or you can give 2 tablets stat. The maximum dosage, usually we go in for 3000 milligram per day, and you can definitely use it for 4 to 5 days. So the advantages you have well elaborated, that it decreases the blood loss by almost 30 to 40%, and it can be very safely used with COCs also. So coming to the hormonal agents, do you prefer going in for progesterone only pills, or are you more comfortable with COCs in adolescent girls?
Ma'am, high dose estrogen has a better effect in such adolescent girls because it causes a rapid stabilization of the endometrium. So we prefer COCs in which we have high dose of ethinyl estradiol between 30 to 50.
Yeah, definitely, Dr. Neha, because these patients, we cannot afford breakthrough bleeding, and we need estrogen component to stabilize the endometrium. So according to ACG recommendation, monophasic COCs containing 30 to 50 microgram of ethinyl estradiol should be administered 8 hourly until bleeding decreases, and then you can taper it down. You can give it on a daily basis. So you've already enumerated the advantages: better endometrial stabilization, superior bleeding control. And what are the indications of progesterone only pills? Are there any indications for progesterone only pills?
The progesterone only pills can be used only if there are any contraindications for estrogen.
And the contraindications for estrogen are like if the patient is a known case of migraine, has history of thromboembolism, hypertension, certain cardiac diseases, or any active liver disease. Or sometimes in girls with PCOD also, where there is a risk of endometrial hyperplasia. So even in those patients, we should avoid estrogen. And other factors are high thrombotic risk, thrombophilias, then estrogen intolerance, if the patient is having severe nausea, and adolescent girls with bleeding disorders where estrogen cannot be used.
Yeah,
So
definitely. Now we have other preparations also. We can give low dose estrogen pills also in such cases. But then if the patient is having intolerance to estrogen, then in those cases you have to give progesterone only pills. These are the only cases in which you give progesterone only pills. And which is your preferred progesterone in such cases, medroxyprogesterone or norethindrone?
ma'am, I'm using norethindrone in such patients, but we can give both preparations. And the dose for medroxyprogesterone is 10 to 20 milligrams, can be given 6 to 12 hourly, and norethindrone can be given in the dose of 5 to 10 milligram every 6 hourly.
Yeah, now we have a wide variety of preparations with us. We have the 10 milligram preparation, we have the 50 milligram,
15
we even
milligram is
have the
also
30 milligram preparation. So sometimes when the patient is not responding to COCs, then you have to, you have to give medroxyprogesterone. You have the 30 milligram preparation also. This Devery tablet is coming in 30 milligram also. So you can give that tablet once a day. Okay, so what about dihydrogesterone? Is anyone giving dihydrogesterone? Is there any role? Dr. Nishi, can you take that? Or it has limited role? Dr. Nishi is not there? Dr. Kanchan? Is anyone using dihydrogesterone?
Ma'am, I am using in just cycle regulation after once the acute bleeding has been stopped.
Yeah. It has been seen that sometimes you can give dihydrogesterone, but it has a limited role, especially as first-line therapy.
Yes,
so not many of us are giving dihydrogesterone, taking into consideration it is pretty expensive also. But sometimes when the patient is very fussy, then you can give. Okay. So what about... just a minute. Is anybody using LNG IUS in adolescent AUB?
No, ma'am. Not in adolescents.
Yeah, in Western countries, they have specific preparations, specific nulliparous LNG IUs, which they are using, but specifically not in India, because here we are not using. Any role of ormifloxacin, are you using it?
Yes, ma'am. We are using it. In some cases, when
So how you are using it, and what are the, in what dosages are you using it, and what is your selection criteria?
Ma'am, if the patient is not tolerating COC or OCPs, then I used to give an endometrial thickness is normal on ultrasound. Then I used to give Novex or this salt.
Cevista.
Cevista.
Yeah.
30, sometimes 30 milligram twice a week or 60 milligram once a week.
Yeah. None of the guidelines actually recommend. We are very short of guidelines for ormifloxacin, but we are very used to, as Indian practitioners, we are very used to giving ormifloxacin. We are very comfortable also because of the easy dosage protocol. But obviously the guidelines do not, neither of the guidelines, the ACOG or International Federation of Gynec and Obstetrics, none of the guidelines recommend it. And it is especially in their specific indications where like you can give it like ovulatory dysfunction, or the patient is not comfortable with routine COCs, or the patient is a little fussy about COCs. No, I don't want to take COCs.
Yeah.
So in those cases, you can give Cevista or this Novex TS. Yeah. So this is given 60 milligram twice weekly for 12 weeks. And then it's more easier than giving daily progesterones or daily COCs, especially also in next category is perimenopausal female in whom the endometrial thickness is normal, and they are also very fussy about taking COCs. In those cases also you can give ormifloxacin. What about the long-term management of such patients? What is the long-term strategy which you advise to these patients? Dr. Richa, once the patient is now like managed, now what is your follow-up advice, follow-up schedule for such a patient?
Firstly, the OC pill has to be continued at least 1-2 cycles. We'll see that the cycle are regulated with this OC pills or not. After that, if we find a definitive cause, like if we are finding some hormonal imbalance, according to that, the treatment has to be given. Otherwise, we can observe the patient. More likely, if she is the cause is an ovulatory cycle, she is likely to stabilize after giving 2-3 cycles of OC pills to her. So we have to observe the patient, and we can after that, depending on the symptomatology,
Both the patient and the parents.
Management. Most of the times it is due to the counseling has
Because
to
they
be
are very
done.
anxious about future fertility
Counseling
issues.
is a very important aspect, because the counseling part is very important. They have to be counseled that it is due to the poor HPO access, and that is likely to settle down, and how much time most likely it will take. It may take from a few months to a year, it may take to settle down. So the counseling part is the most important part.
Also teach them to identify abnormal bleeding. That's really important.
Yeah.
Yeah, if there is any bleeding for
Yes,
more than
that is
7 days or passage of large clots, then only they can. There are the red flag signs. What about the menstrual tracking? They can keep a menstrual diary, and they should keep a record of the length, duration, and the number of pads.
Yes.
And what about the iron therapy? Supposing she's having anemia, how do you advise the iron therapy?
Depending on first of all, depending on whether it is mild, moderate, or severe anemia in this patient, we'll be treating according to the grade of anemia, like oral therapies, iron-rich food, and green leafy vegetables. First, nutritional advice has to be given. Then the supplements have to be added. Most likely, oral supplements. We have to, especially if this patient is in adolescent girl, she has to be told, especially how it has to be taken, because and about the side effects as well have to be explained to the patient as well as to the parents, because again the counseling is very important. And similarly, if she is a patient of PCOS, then weight counseling, regular exercise, weight management, and a healthy sleep pattern, all these things are to be explained to the mother as well as to the patient.
Yeah. Follow-up and reassurance is really very important. And with this, we come to the red flag symptoms, which you should need to tell the patient that, yes, if you are having any such problem, very heavy bleeding, then you can come up to us and you can show it anytime. And follow-up scheme, you should tell about the clearly define the protocol to review in 3 months or 6 months as per her symptoms and signs, as per her hemoglobin levels, because really it is very important, as Dr. MC Patel sir has also said, that documentation follow-up strategy should be very well counseled and explained to the patient and the attendants. So with this, we come to a rapid fire question. We have just 2-3 rapid fire questions. And okay, so can you see? She's a 13-year-old girl, and her menstrual bleeding is lasting 10 to 12 days every cycle. Hemoglobin is 8.5. She reports frequent epistaxis, and her mother required multiple blood transfusion after childbirth. PT and APTT are normal. What is the most appropriate next investigation?
C. Ma'am, von Willebrand's.
C.
Von Willebrand's factor.
Yeah, definitely, because the normal PT and APTT does not exclude von Willebrand disease. So heavy menstrual bleeding from menarche plus mucocutaneous bleeding and positive family history strongly suggest an inherited bleeding disorder. So up to 20% of adolescents presenting with heavy menstrual bleeding have an underlying bleeding disorder, which is most common as von Willebrand disease. Second question. She's a 13-year-old adolescent with heavy menstrual bleeding. Hemoglobin is 7.8 grams. She's hemodynamically stable. The history is suggestive of thrombosis or migraine. The most appropriate first-line hormonal treatment here is
C.
C.
Doxyprogesterone.
C.
COC.
COC.
Yes,
Yes, yes.
high-dose monophasic COCs containing 30 to 50 microgram of ethinyl estradiol is the preferred first-line therapy for acute severe abnormal uterine bleeding, because obviously we have studied a lot that estrogen rapidly stabilizes the endometrium. Which of the following is an indication for pelvic ultrasound in an adolescent with AUB?
Persistent
D,
heavy bleeding
Persistent
despite
heavy bleeding.
Persistent heavy
Despite the
Despite
bleeding
treatment.
despite treatment.
D, persistent bleeding. Routine ultrasound is not recommended in initial adolescent, but if there is failure of medical therapy, then only you can go in for an pelvic ultrasound. Okay. So 14-year-old girl is diagnosed with von Willebrand disease. She does not want to go in for hormonal treatment. Which therapy has the strongest evidence as a non-hormonal treatment?
Tranexamic acid.
acid during menses.
Perfect. Hands up. Tranexamic acid is the preferred non-hormonal treatment for heavy menstrual bleeding, particularly in bleeding disorders. Last but not the least, a 14-year-old girl, she is presenting with 110 and 70 millimeter BP pulse 96. She is not actively bleeding at present and has no cardiovascular symptoms. The most appropriate management.
High dose hormonal therapy with iron.
Okay, yes, this is very right that immediate blood transfusion, we don't go in for immediate blood transfusion in adolescent females unless and until they are hemodynamically unstable. Okay, so you have to, we need to emphasize that adolescents generally tolerate anemia well, and the decision to transfuse should be based on hemodynamic status. Thank you. Dr. Monica, you can go ahead with the second.
Yeah, thank you so much, Vardha. So can I share my screen? Arna, देखो. Arna, देखो.
बेटा आप
देखो Arna. देखो ना बेटा कैसे. Should I open this screen? Entire screen desktop. ना तो ये खोले. Is my screen visible?
Oh, ma'am, previous
Yes,
screen
ma'am.
should be. I can't see the.
Ma'am, you need to go to the slide share option.
Slide share.
The cup-like structure at the bottom.
Okay. Yeah. Can you see now? Full screen.
नहीं, वो इंटरनेट चला गया था बाद में.
No, ma'am, not yet.
I have shared my PPT in the group. If anyone can share, I will try to share again. ना देखो ना बेटा. देखो ना, कोई फर्क नहीं पड़ता. इसको मिनिमाइज करो 1 मिनट. जल्दी करो बेटा.
Click on the share button at.
Yeah, I'm trying to do that. एक मिनट. ऐसे आ जाओ ना. Just give me 1 minute.
Yeah, yeah.
ये नहीं, इसको मिनिमाइज करो. ये मिनिमाइज करो बेटा. ये करो, सीसी करो. हाँ, अब शेयर करो. अब इसको मिनिमाइज करो पूरा प्रेजेंटेशन. शेयर किया.
Ma'am, I have shared the screen if you are comfortable.
Yeah, I that's why I shared the PPT with you. I thought if I will share it, Anna करो, it will be easy for me to moderate.
Yeah.
Anna देखो ना बेटा, ये देख लो. Just give me 2 minutes. अगर नहीं होगा तो फिर शेयर करो. वो खोलो मेरा, वो कहाँ गया? वो खोलो बेटा. अब वो भी चला गया. अब ये खोलो 1 मिनट. शेयर स्क्रीन. डेस्कटॉप ही तो मैंने शेयर किया था. इधर वन ऑफ दीस माइक्रोसॉफ्ट है. इनमें से देखो मैं. माइक्रोसॉफ्ट पावरपॉइंट. ये देखो अननोन तो नहीं था. अननोन नहीं है, उसमें नोन है. ओपन सिस्टम सेटिंग्स. क्या है? करें तो मॉडिफाई. नहीं हुआ, इसको करो यार, खींचो उसको, अब तो दिख भी नहीं रहा मुझे कोई भी। कोई 10 ओपन रीओपन आ रहा है ना, तुमसे मैं कहा था पढ़ के देख लूं। अब कैन यू सी माई स्क्रीन नाउ?
नो मैम।
वर्धा यू शेयर प्लीज।
मैंने शेयर कर दिया मैम।
अच्छा, तो मुझे दिख नहीं रहा है, ये तो मुझे मेरा दिख रहा है ऑन माय लैपटॉप। ये इसको खोलो, इसको ये, अच्छा एक मिनट को। वर्धा यू विल बी शेयरिंग द स्क्रीन, सो यू विल बी शेयरिंग
नहीं दिख नहीं रहा है क्या?
नहीं, मुझे दिख रहा है, सबको दिख रहा है।
यस मैम।
यस हाँ, सबको
अच्छा।
दिख रहा होगा मैम।
Okay.
Yes, ma'am.
So a very good evening, and I'm Dr. Monica Agrawal, and at the outset, I would like to thank Dr. MC Patel, sir, Dr. Preeti Kumar, ma'am, and Dr. Seema for this opportunity. So as just now Vardha has completed with the adolescent AUB, I will try to take up the reproductive ones. Next, please. So why abnormal uterine bleeding needs a common language? Because it is present in 3 to 30% of the reproductive aged women worldwide, and 1 in 3 women are affected by AUB at some time in point in their reproductive life, and more than 50% may not seek medical care or may have not access to it. So as you all know, FIGO has published the AUB system 1 and 2 systems for the classification of AUB. Next, please. And these inconsistent terms like which we were using previously, like the menorrhagia, metrorrhagia, dysmenorrhea, dysfunctional uterine bleeding when we were studying as resident. Now we are not using all these terms. Next. So we are all familiar with the acute versus chronic AUB. Next, please. So according to the FIGO, AUB system 1 is based on the symptoms of the symptomatology of the patient, and it was revised in 2018. So we should know, as Vardha rightly told, what is normal and what is abnormal. So what is the normal duration or frequency of a normal menstrual cycle is 24 to 38 days, and the duration is normal is less than or equal to 8 days. And the regularity between the shortest to the longest cycle variation should be less than 7 to 9 days, and this is variable according to the age of the patient. Also, the flow volume has been divided normal, and it should be, as Vardha has told the definition of AUB according to the WHO, any quantity that is affecting the physical quality, mental and the emotional well-being of the female will be included as CUB, AUB. Next, please. So there has been certain changes from the 2011 to 2018 classification of the FIGO, and the major ones are like in the frequency. Now we include amenorrhea is now part of the frequency category. Regularity, as I told you, it is 7 to 9 days, and that is age dependent. Now the duration has 2 categories only, that is normal is less than 8 days and prolonged is when it is more than 8 days. And the volume, it is already we have according to the WHO criteria of the quality of the life of the female, and intermenstrual bleeding is the newly defined symptom. Next, please. PALM coin has been nicely told by you all, and it is based basically on the causes. First is the PALM is the structural and the coin is the non-structural causes. Next, please. So there has also been certain changes in the PALM coin terminology or the classification in the 2018 in the revised FIGO. In this, we have seen that we will see that there is a refined sonographic MUSA-based diagnostic criteria for adenomyosis, and type 3, which was previously not included as submucous, has now been regarded as the submucous. AUB-C, in which we were including the anticoagulant related bleeding, is now no longer in anticoagulant related bleeding is included in AUB-C. It has been categorized in AUB-I. And AUB-N, we now don't clause is not yet classified. We call it, it has been renamed as not otherwise classified. And this will include usually the cesarean scar niche, ischemosue, atriovenous malformation, arteriovenous malformations, and the endometritis. Next, please. So coming on to the first case. So Mrs. X, 40 years, and she is a housewife, para 2, living 2, previous 2 normal deliveries, last child birth was 18 years back. And she is presented with us with the progressively worsening heavy and prolonged menstrual bleeding, severe dysmenorrhea for the past 12 months, and she also reports passing of large clots and occasional flooding, deep dyspareunia, and a sensation of pelvic heaviness. And she is now presenting because the bleeding is affecting her daily activities and is also associated with fatigue. Next, please. So if we see the symptom parameter, the frequency is 15 to 20 days, duration is 8 to 9 days, regularity, that means they're irregular more than 9 days, flow volume, she's changing 4 to 5 pads per day associated with clots and occasional flooding. Next. There is no use of any current contraception, no anticoagulant or any other medication she is using. On examination, there is mild pallor, BMI is 27, abdomen, uterus is just palpable and corresponds to 14-week size, mildly tender, cervix is healthy, no polyp or any lesion is seen. Bimanual examination, uterus is 14-week size, mobile, mildly tender, no adnexal mass, no nodulity in the pouch of Douglas. Next. So, Dr. Nishi, can we have a differential diagnosis? What all comes to your mind when we are getting a patient like this? Next, please. She is not there. Anyone can answer. Please,
Okay, ma'am.
I think Dr. Nishi is not there. She wasn't answering she was in the wasn't there.
Please, anyone can take up the
Yes, ma'am. I
May
am.
I answer?
Yes,
Okay,
ma'am.
we'll exclude the pregnancy. We'll exclude the pregnancy, and there may be structural causes also. So we may think of adenomyosis and fibroid, and since she is in perimenopausal age group, we'll also think of malignancy.
Yeah. So first of all, it is very important to remember that any female that is in the reproductive age group, we have to rule out pregnancy as the first investigation. Then only we should proceed ahead to find out the other structural and the cancer causes. Next, please. So how can we confirm the diagnosis of adenomyosis? How will you confirm? Dr. Kanchan, anyone can take?
Ma'am, we will go for an ultrasound. First, history taking, proper history taking, the number of days of periods, the symptoms which she's facing, examination, per speculum, per vaginal
So
examination.
is there any specific pattern of menstrual bleeding in cases of endometriosis? Or this is adenomyosis?
Ma'am, the bleeding is heavy and it is associated with dysmenorrhea. Dysmenorrhea is a typical feature of adenomyosis, and it is associated with passage of clots. Heavy bleeding is there. So we need to go for diagnostic tools like ultrasound. Transvaginal ultrasound is specific. We can go for 3D ultrasound, and on transvaginal ultrasound we can know the diagnosis of adenomyosis. We can see the lakes, the myometrial
Yes, we are just coming to it. So perispeculum examination is very important, because sometimes what happens when nowadays many people are now doing perispeculum examination. I think we should emphasize on doing perispeculum examinations to our residents and everyone whom we are come in contact, because sometimes we are looking for great things and we miss a small polyp that is we can see coming out through the cervix. So it is always a good idea to do a perispeculum examination and a good PV, especially telling us about the uterine size, about the mobility, even about the consistency and the side to adnexal tenderness or any side to side mobility. So these all features we should look for, because once we are good in clinical, we can make, I think if we just do these two things, history and good examination, we will 90% of the patients we can make a diagnosis. So what is the role of imaging? So as we all know, I think Neha told, it is the first line imaging, of imaging in adenomyosis. And we look for the typical features of adenomyosis. We also look for the location, whether it is a local or diffuse involvement, where there are presence of cystic lesion. We also want to see the extent of the lesion and the lesion size. So there is a MUSA, that is the morphological ultrasonographic assessment of the adenomyosis, and that in which we have seen certain features like the asymmetrical myometrial thinking, like in the figure A. You can see here that the posterior wall is more thickened than the anterior one. These are the small myometrial cysts, hyperechoic islands, fan-shaped shadowing, echogenic subendometrial lines or buds, and even the translesional vascularity, irregular you can see the junctional zone. It is a very good thing to look at the junctional zone to look for the adenomyosis, to come to a diagnosis of adenomyosis, and also an interrupted junctional zone. So all these criteria are very important to come for to help us. They help us in making the diagnosis of adenomyosis. So then my next question to Dr. Shailja. Now, if you have a good ultrasound and you have done and you have made a diagnosis, would you like to do a MRI? Is it mandatory? Shailja, can you hear me? Anyone can take? Shailja is here.
No, ma'am.
Ma'am, MRI is indicated only. Ma'am, MRI is indicated only when there is a diagnostic dilemma or when transvaginal scan is not possible. Sometimes when there is a doubt between fibroids and adenomyoma, we may need an MRI and also for mapping of fibroids before surgical intervention.
Yeah, so as such, we should not, because it is costly, especially in government setups like we are working. So we should try to avoid writing an MRI until unless it is a mandatory part of our investigations that we have to write it. So I think if you have a good transvaginal ultrasound in your setup, that is cheap for the patients also, easy to do also. So you should try to go with an transvaginal ultrasound only. And if you want, you can use an 3D or also you can use a color Doppler. Next, please. So the investigations in this case, her hemoglobin was 9 gram. On TVS, the uterus size was enlarged. It has altered ecotexture, globular with asymmetrical thickening, multiple small myometrial cysts, hyperechoic islands were present in the myometrium, and bilateral adenexa was normal. Next, please. So according to this, now we have come to a diagnosis that palm coin, that it is A. So any confusion till now? So I think we have come to a diagnosis by a history. What were the findings which suggested? Because she had severe progressive heavy menstrual bleeding, dysmenorrhea, also in the examination, the uterus was enlarged, 12 to 14 week size, mildly tender. I think किसी ने देखा कि नहीं, I don't know, but it was mildly tender and enlarged. So what is the 2020 MUSA criteria for adenomyosis, and what is the minimum requirement? So this MUSA which we are reading, it was in 2015, and it was revised by experts to define more adenomyosis by ultrasound more nicely. So anyone can tell?
Yes, ma'am. There are direct features and indirect features. The direct features include the myometrial cysts, hyperechoic islands, and the echogenic subendometrial
Next slide, please.
Lines and bursts. And the indirect features include the globular uterus, asymmetrical myometrial thickening, fan-shaped shadowing, irregular junctional zone, and translesional vascularity. And at least one direct feature should be present for a sonographic diagnosis of adenomyosis.
Yeah, because what are direct features? They are the features which are because of the presence of endometrium in the myometrium, ectopic endometrium in the myometrium. What are the indirect features because of? They are because of the secondary changes in the myometrium that are due to the presence of this ectopic endometrium. Very rightly said, Shivangi. Next, please. So how can you differentiate adenomyosis and fibroid clinically and by ultrasound? Anyone? I think we have covered.
Clinically, there will be more symptoms of pain related to in cases of adenomyosis, like dysmenorrhea, dyspareunia.
Even
these are little less in fibroids, and in perimenopausal age group, adenomyosis is more common.
Yeah.
On examination, also adenomyosis will be it may be tenderness may be present in that. And on ultrasound findings, we have a well-defined mass in case of fibroid.
Next, please.
There
Next
will be peripheral vascularity.
Varda, please shift the slide, change the slide.
There will be peripheral vascularity in case of leiomyoma.
Next slide, please, Varda.
And on ultrasound findings of adenomyosis, there will be presence of MUSA criteria, myometrial cysts, fan-shaped
lot of findings we can find on
hypergenesis.
adenomyosis, and usually on ultrasound in the fibroid, we will find a hypoechoic, usually a hypoechoic, well circumscribed mass and covered
With
by a
peripheral
pseudocapsule.
vascularity.
Yeah, and with a
Yes.
peripheral vascularity. Next,
Yes,
please. Varda, are you there? Yes, so you can see this is a normal uterus, diffuse adenomyosis and focal adenomyosis, and that's good. You can see in the second picture, this is a big fibroid you can see, which is a hypoic, well circumscribed mass. Next, please. Next, please. Next slide. Varda, are you there?
Yeah, I'm there. Just
Next, please.
I don't know. It's not moving.
No, एक मिनट खोल दे.
Just give me a moment. It's not moving actually. Is it showing now?
Yes, yes.
Can you make it full screen, please?
Yeah, I'll try because I don't know. It was just stuck there. कुछ hang हो गया, I think might be. ठीक है अभी?
Full screen. Yeah, now it is okay. Thank you, Varda. So what are the management option of adenomyosis, Dr. Richa? Next slide.
In cases of adenomyosis, first of all, we have to individualize the treatment depending on the age, symptoms, and desire of the future fertility, and if there is any associated lesion, as like if leiomyoma is there, or some polyps or associated endometriosis is there. So that has to be titered according to
we
the
cannot form a guideline
patient to
for
patient.
Yeah, we cannot form the same guidelines for a 20 years or a 30 years female and a 40 or 50 years female. So the treatment options we have, yes, Richa, you can tell. So
Treatment options are, first of all, medical therapy. Like first line management will include, the goals will be to control AUB. First of all, she's bleeding. The first thing we have to do is control AUB and dysmenorrhea, and then reduce the uterine size as it is to a 10 to 12 week size. So this we have to do. So options that are available are LNG IUS is the most effective one, and particularly for this age group, it is very good to give LNG IUS option. Then for the control of bleeding, antifibrinolytics like tranexamic acid can be given. And NSAIDs will be required only if she is complaining of severe dysmenorrhea, as it will be there in cases of adenomyosis. So NSAIDs may be required. Then GnRH analog, combined hormonal contraceptives, and cyclical progesterones, they may also be given in this case,
So
depending on the affordability. And
yeah. So my one question, what are you people using for adenomyosis? How many are using LNG IUS? How many are using GnRH? What is the most preferred medical therapy that you are giving to your patients?
LNG IUS is the best option.
Okay, good. So so the surgical management, we have a uterine preserving surgeries like the adenomyomectomy, that is for focal adenomyosis. If patients want to conceive and she wants to preserve her fertility, hysteroscopic resection in superficial adenomyosis, uterine artery embolization, and we can also go in for a high intensive focused ultrasound. And definitely always remember that the definitive treatment of adenomyosis is total hysterectomy. Next, please. Varda, please. Next.
I'm free. Give me it.
So this is the treatment algorithm of AUB-A. So in a woman with AUB due to adenomyosis, we have to look for whether the patient is desirous of fertility or whether she is not desirous of fertility. And if she is desirous of fertility, then definitely LNG IUS is the recommended first line therapy. However, if due to some reasons the patient doesn't want to use LNG IUS, or she is resistant to that, then we can go in for a GnRH analogs that are very good, and we can give it for 3 cycles at least, and it will be better if you give them with add-back therapy is recommended, and this is the second line treatment. And the women who are not desirous of fertility, we can group medical manage. If you want to do the medical management, we can give you we can try LNG IUS as the first line, or long-term GnRH agonist with add-back, or if there is a failure or refusal of management, then we can go in for a hysterectomy. Next, please. So now we have talked about the medical and the surgical management. Now suppose a patient was going on some LNG IUS. Now what would prompt you to proceed to hysterectomy in this case? Dr. Sonam, if you are there.
If she's not wanting to continue for LNG IUS, or if the symptoms are still very severe and are persisting, and she is of perimenopausal age group or around 40 years, and her family is completed, she has no fertility issues, and symptoms are severe and diffuse adenomyosis are there, then we can go for hysterectomy.
Yes, very rightly said. And if there is a failure or intolerance to the medical therapy. ठीक है. So with that, how much time we have? Next place, please. Next slide. Can we go quickly for the other case also? Do we have time? So the take-home points are adenomyosis presents classically with HMV plus progressive worsening of dysmenorrhea in a Paris woman in her 40s. The uterus is usually bulky, globular, tender, without discrete masses or cul-de-sac nodularity, and it is useful in the diagnosis. And through 2022 MUSA criteria is the recommended first-line diagnostic tool with more than one direct cause of adenomyosis. Systematic exclusion of the remaining palm coin classes is essential before assigning any treatment, and LNG IUS is a reasonable first-line therapy once the childbearing is complete, and hysterectomy remains the definitive option for refractory cases. So coming on to the scenario 2, she is Mrs. Previous slide, please. So she is Mrs. X, 48 years, para 3L3, presents with irregular and intermenstrual bleeding for 6 months with I can't see this. What is this? With occasional heavy episodes. Her cycles have become unpredictable over the past year, varying from 18 to 14 days, and duration is 8 to 10 days, with unscheduled spotting between the periods. BMI is 33, vitals are stable, mild pallor is present, abdomen is soft, non-tender, there is no pus could be palpable, speculum examination is normal, you can see a scant bleeding at the os, and bimanual uterus is normal size, mobile, non-tender, and adnexal mass. There is no adnexal mass. Next, please. So how would you like to approach this patient? Dr. Nishi is not there. Anyone else can take this.
Ma'am, after ruling out the pregnancy, we will do the CBC, thyroid evaluation, TVS, and identify the risk factors as obesity and chronic anovulation. And if everything is normal, then endometrial sampling should be done to rule out hyperplasia and malignancy.
And if the patient is not bleeding, we should always try to take out the pap smear at the same time.
Yes.
So that we can rule out any CINs or any cervical intranatal dysphagia that might be present along with the this thing. So on our laboratory and imaging findings, beta HCG is negative, hemoglobin is 9.2, TSH is within normal range, and the transvaginal ultrasound shows an endometrial thickness of 14 mm, heterogeneous ecotexture, no discrete polypores of mucosal myoma, and there is no adnexal mass. Next, please. So now here comes what are we going to do next and what is the role of imaging? Dr. Kanchan, are you there? Anyone?
Ma'am, she's not there. Role of imaging is very important in this case. First, as we have done the initial management, now we'll go about with the imaging thing, that is the transvaginal scan is mandatory to evaluate AUB, to evaluate the size, adnexa, and endometrial thickness, as we have already done. Then Doppler USG is suspected cases of AV malformation, and to differentiate between fibroid and adenomyosis, and if there is any suspicion of malignancy in these cases. And 3D USG may be done if it is available. MRI is also indicated in some cases where we need the mapping, fibroid mapping, and line of management has to be decided.
So basically for all these cases, the first line imaging modality should be transvaginal ultrasound with a 3D and a color Doppler. And is there any role of SIA, saline infusion sonography, what we call, Dr. Renu or anyone else?
Yes, ma'am. When we can't find the polyp or submucosal fibroid on TVS, it can clarify it because it improves the cavity visualization and helps to determine whether the hysteroscopy is needed or not.
Yes, and especially sometimes what happened in a PSC or a small place, sometimes the 3D ultrasound and the hysteroscopy are not available. So then also we can go with a saline infusion sonography. It is a very simple test. You have to just insert a pediatric Foley's and fill the uterus with 3 to 5 ml of normal saline. Next, please. Is there any role of MRI? I think this has been taken. Next, next. So it is usually done to map the exact location of fibroids, and it has been used prior to therapeutic embolization for fibroids. Next, please. So my next question to Dr. Shailja. What are the indications for doing endometrial sampling? What is the technique, and can we do it in a woman who is less than 40 years? Or should we do it in a woman who is less than 40 years? Next, please.
Ma'am, endometrial sampling is indicated in women more than 40 years who are presenting with AUB, and in women less than 40 years if we are suspecting endometrial carcinoma, or if endometrial thickness is more than 12 mm. After 40 years, women presenting with AUB, endometrial sample can be obtained with a PIPL, or we can go for hysteroscopy and guided biopsy. And in less than 40 years, if the woman is at an increased risk of endometrial cancer, we have to go for endometrial sampling.
So what will be the risk factors like the irregular bleeding?
The risk factors are when the woman has unopposed estrogen stimulation of the endometrium. For example, if she has PCOS, diabetes mellitus, obesity, and if there is a history of breast or ovarian malignancy, or if she has taken tamoxifen for postmenopausal hormone therapy or for breast cancer, or if there is abnormal uterine bleeding which is unresponsive to medical management, or if there is a family history of breast cancer, ovarian cancer, endometrial cancer, or colon cancer. So in these women, endometrial sampling has to be done. Ideally, it should be done after hysteroscopy, but we can go for PIPL and aspiration.
So it will basically be an office endometrial biopsy. How many of you are doing dilatation and curettage? Anyone doing dilatation and curettage? For the biopsy, for the histopathology? No, I think nowadays
dilation and curettage is not done.
So we are basically, when we were residents, we were doing this DNC to find out the tissue, because it was thought that it is both therapeutic as well as diagnostic. But now we are just not doing all this. So as Shailja has rightly said, we can do the sampling with the PIPL or the Vebra aspirator. Next, please. And what are the pitfalls for this PIPL endometrial sampling? Next, Dr. Neha.
And if the area of involvement is less than 50%, then the cancer can be missed. So the false negative rates are high. The sampling may be inadequate, and other pathologies like polyps may be missed. So
sometimes it is difficult to negotiate the odds when you are in a OPD without any sedation or that. And role of hysteroscopy, Dr. Sonal?
Yeah, ma'am. When we are suspecting an intracavitary structural pathology like polyps, and it is very good since it is both diagnostic and therapeutic in one sitting only.
Yeah, well, yes. And the sensitivity of detecting an intrauterine pathology with a hysteroscopy is much higher than that with the PIPL and a Vebra aspirator. It is as high as 98%.
Yes.
And it will provide also an excellent view of the cavity, the polyps, norma, and
provide a direct view.
Yeah. So it is a role of hysteroscopy is it is recommended in cases of by the RCOG. Back please. Okay. In office, endometrial sampling fails or is non-diagnostic, and when the endometrial hyperplasia is diagnosed within a polyp or a discrete focal lesion.
Yes, ma'am.
So next, please. What are the contraindications for hysteroscopy? Anyone?
When there is an active pelvic infection of vagina, of pelvis, vagina, or cervix, or there is pregnancy.
Yes.
Then we'll not do hysteroscopy.
Or there is a recent perforation in the. If there is a history of past perforation, then we can go in for a hysteroscopy. So what is the ideal time to perform this hysteroscopy?
Post-menstrual. In the premenopausal women, we can do it in
time of a menstrual cycle. Time of a menstrual cycle.
Just after the menses.
Yeah. Next.
Just after that is 6 to
next. So usually it is done in the proliferative phase immediately, post-menstrual phase, and post-menopausal any time according to the indication. Next, please. So the patient, what was the, we did a endometrial biopsy in this patient, and it came out to be endometrial hyperplasia without ATPR. Next, please. So as we all know, according to the WHO 2020 criteria, the classification has now been changed, and now we call it hyperplasia. We classify basically endometrial cancer into two: hyperplasia without ATPR and hyperplasia with ATPR, or the endometrial interepithelial neoplasia. Next, please. So this will fall. Our diagnosis now is AUBM. because all the hyperplasias are also included in the M. So as you all know, endometrial hyperplasia is because of the prolonged unopposed estrogen stimulation. Next, please. So we have talked already about the risk factors. We can skip this. So how would you like to manage a case of endometrial hyperplasia without atypia?
LNG-IUS is the first choice of the treatment, first line treatment. Then we can give continuous oral progesterones, weight reduction, metabolic correction, and biopsy every 6 months.
Yes. So LNG, you should not be tension free that once you have put an LNG ICU, you know, you're going to send the patient home and you're going to call that patient after 5 years. So this is very important. Though this is a case of endometrial hyperplasia and atypia, you have to keep the patient in follow-up for a long time, and the patient will come back to you every 6 months for an endometrial biopsy. So LNG-IUS is the first medical or the conservative therapy that we can give in a case of atypia. Otherwise, if the patient is non-compliant or she doesn't want LNC, then what is the next line of treatment?
Progesterone.
Long-term progesterone.
Long-term.
Yes. So long-term, and remember that you have
Continuous.
to continuously. You have to give progesterone not cyclically, but continuously. And basically, as someone has told, we should also try to control the high-risk factors which are controllable, like the diabetes, blood pressure, the weight gain, and reassurance and counseling is very important in these patients. You have to ask them to come for biopsy every 6 monthly. And if the more than 2 consecutive negative biopsies are there before you can discharge the patient, and hysterectomy only if it is progressing to atypia. There is no regression after 12 months. There is a persistent bleeding, relapse, or patient wants to go in for a hysterectomy. Next, please. So a short, anyone wants to cover this? Management of endometrial hyperplasia without atypia, we have already covered. Next, please. So what are the advantages of LNG-IUS? Why we want to use it? Sorry. Yes, anyone want to?
Yes, ma'am. There are excellent regression rates, superior bleeding control, and there is long-term treatment up to 5 to 7 years. They are quoting now 7 years.
7 years.
Minimal side effects, contraception, and there is reduced need for the hysterectomy.
Yeah, and sometimes what happens by this, once you are putting like
dysmenorrhea is corrected with this.
Initially, the patient might complain of, for the first 3 months, might complain of mild spotting and bleeding, but that we can help to counsel the patient, and we have reassure that it will be connected in the another 3 to 4 months. So, and basically it is an outdoor procedure. You don't need to, it is nothing invasive is being done. You have to just put it is just like a copper T incision, but it's very simple. So what are the problems faced with the LNG-IUS?
Irregular spotting, sometimes expulsion, there is breast tenderness, acne, weight gain.
All the progesterogenic side effects that we have in the oral OCPs, they are with the LNG-IUS also.
But they settle within 3 to 6 months.
Yeah, but though they are mild, but they are very troublesome to the patient. Next, please. So this is the all indications where we can use an LNG-IUS for the first line of treatment in cases of AUB, like the AUB-P, that is the polyp, adenomyosis, in leiomyoma when it is intramural subserosal leiomyoma type 3 and 4, and AUB-M, that is hyperplasia without atypia, and ONE with COCs are contraindicated when the patient doesn't want to take COCs or they are not availing. Iatrogenic, and N not otherwise classified. Next, please. Next, please. Vardha, are you there? So follow-up of a patient of endometrial hyperplasia.
2 consecutive biopsies are negative, 6 monthly.
So that is for without atypia.
Without atypia. And for atypical endometrial biopsy every 3 months until 2 consecutive
negative biopsies are obtained. Next, please. So what is the algorithm for managing an endometrial hyperplasia with atypia? What is the ideal treatment for these patients?
And if
Ma'am,
the
the
family
ideal
is
treatment
completed, then
of
hysterectomy.
endometrial hyperplasia with atypia would be hysterectomy. But if the woman does not wish to go for hysterectomy and
Next,
wishes to
please, ma'am.
conserve her fertility,
Next slide,
then
please, Varda.
we can give her levonorgestrel intrauterine system or continuous oral progesterone.
Yeah. So again, here we have to be very careful if we are offering them conservative treatment. We have to evaluate them for the invasive endometrial cancer and the synchronous. Sometimes what happens, the endometrial cancer is present along with the ovarian cancer. So we have to counsel them and we have to rule out both these cancers before we are putting them on conservative treatment. Next, please. So continuous, we know we can give continuous medroxyprogesterone acetate or the norethistron acetate. Cyclical progesterone therapy is not recommended in this thing, hyperplasia. Duration for atypia is minimum of 6 months, and you can, if the patient is well tolerated, you can with the LNG IVCs can be retained for up to 5 years. Next, please. So AUB is a common problem from menarche to menopause in India, and PALM-COING system simplified the clinical classification and provided an organized approach for the diagnosis and evaluation. The approach should be individualized, and we should offer the patient a cafeteria approach. Medical management for AUB is the first line of treatment. Hysterectomy is the last and the late resort, and evidence-based management can avoid number of unnecessary hysterectomies. So thank you all my panelists and all who have contributed so nicely, and it was a good panel discussion with good take-home messages. Varda, are you there?
Thank you everyone for making us a part of it.
And
Thank you, ma'am.
Thank you, Varda, for sharing the slides.
Thank you, MC Patel sir, and all the organizers and
Thank
all the
you.
moderators, ma'am. It was a very good discussion.
Do we have any expert?
Thank you so much.
Patel sir is there.
Thank you, Patel sir. Thank you, Monica ma'am. Thank you, Dr.
Thank
Deepika ma'am.
Thank
Thank
you,
you, Monica ma'am.
Dr.
Dr.
Patel
Varda
is-
ma'am, thank you. It was a very informative session.
Dr. Patel is there? Any expert?
No, ma'am. Dr.
Sir, would you like to say
So
anything?
big round of applause for two learned moderator and all the panelists, making panel very interesting and fruitful. Thank you.
Thank you, sir, for making
Thank
us
you,
a part of it. Thank you, sir, for giving us this opportunity.
Sir, we have one more case on postmenopausal bleeding, but I think we don't have time.
No, time. Because it is already 9:30.
Yeah, sir.
So we
Thank you
can
so much. Thank you so much for the opportunity, sir.
Yes. Satabdi, we can conclude. Any coordinator? Satabdi, Monica, Nivedita. Anyway, thank you all to participating in this webinar, and thank you Corona people for continuous educational support to this series. Thank you very much.
Thank you so much, sir. Thank you so much, MC Patel, sir.
Yes.
So, shall I end up?
Oh, yes, we can conclude.
Okay, sir. Thank you so much.